about to get started. Welcome back to day 3, part 2 of week 2 of our budget hearings. Thank you. Yes, thank you. That's very creative. I appreciate that. Thank you, sir, for that. Before we start, this is the second time? Somebody is spending their birthday with us this afternoon. Double G is in the building. That's my new name for you. See that? You see how I gave you a name?
Thank you.
Let's say happy birthday to Gloria Gilligan for her birthday today. I feel like it was your birthday the last year too.
It was, Chairman.
See,
it absolutely was.
We have a special bond here. That's what this is. This is all about you. I appreciate that. Happy birthday.
Thank you.
All right, we're going to jump right into our questions, and we'll start with Representative Kincaid.
Thank you, Chairman. Thank you, Secretary, for being here. I want to start. Funding for our rape crisis centers was flat funded again this year, and I'm wondering if you can tell me whether the need for rape crisis centers has flatlined as well.
Yeah. Thanks, Representative. I do appreciate that question. You know, I think the need is not flat. I think it's fair to say. I have visited a couple of these centers myself. The folks there are doing incredible work. I particularly like to give a shout out to many of the attorneys who work in these centers providing legal services for the folks that they represent, and they could be in very different job situations in terms of income and other things. So the people that work in these centers are really incredible and so committed to that work. And this is one of those areas where I know it's been an extremely difficult few years in the budget. And I think if there is a proposal that the General Assembly wants to bring forth, I'm sure people would be happy to take a look at it.
Thank you. DHS contracts with organizations to push out funding for certain line items like the domestic violence line item. And those organizations are entrusted with taxpayer dollars. And I think the people of Pennsylvania have a degree of assumption, I guess, that those organizations will behave responsibly. However, I've been troubled to learn that DHS has no grievance process for sub-grantees of that money, where they would be able to alert the department to behavior that weaponizes taxpayer dollars when the contracted organization is trying to use them in order to force compliance on things that are not actually part of the contract. What changes will DHS be implementing to ensure that Pennsylvania taxpayer dollars are not being improperly used as a stick to beat organizations into compliance with the will of the contracting organization?
So I think you're referring to an organization that is a grantee of DHS. Grantees, in that case, that was the result of a procurement, the particular grantee that was chosen. And that grantee is tasked by us to provide oversight of their sub-grantees. And they have to report back to us that sub-grantees are spending taxpayer dollars as is consistent under the grant agreements. And so that is the existing process. The sub-grantees have reporting requirements to the person that we grant to. And there are, from time to time, disagreements about how funds are flowing and whether or not those funds are being used in the way that they were contracted to be used. The sub-grantee should have a grievance process with the person that they are contracting with. And that is the process as it exists today. We do hold the grantee accountable for both their work and then their sub-grantees in terms of financial monitoring and meeting all the requirements of the grant.
I appreciate that. Unfortunately, what we're seeing is where the grantee is actually putting additional requirements and using taxpayer dollars to do it, and that the sub-grantees don't have an ability to alert the department to sort of an abusive relationship in that capacity. And I would encourage the department to create a grievance process for that, because the department should be able to know if there is a problem that the grantee does not actually feel the need to resolve because they are benefiting from this imbalance of power.
Thank you.
There is also nothing in the budget proposal for moving EBT to dedicated chip cards. Can you talk about how DHS is planning to improve the security of EBT cards, especially because right now with the smartphone apps, we are shaming participants for having smartphones because they aren't not DHS, but there's often a conversation on that that they would have a smartphone. So what are your plans to make that security feature more accessible to all SNAP users?
So we did recently send over a report in terms of the cost for providing cards with a chip. That cost in total is around $17 million. Unfortunately, we've been talking about HR 1 all day. One of the things that's happening in the SNAP program is that we now have to pay 75% of administrative costs instead of 50% of administrative costs, and that will apply to the cost to implement a chipped EBT card. So that's frustrating. So we're going to have to pay a bigger share of that $17 million should the General Assembly decide that they want us to proceed with that. In the meantime, we have been, and this is all in this report, we have been looking at what's been going on in other states. There are 3 states that have been trying to move forward on this, and all 3 have had various degrees of challenges. There are only 2 EBT card vendors in the United States. That's not our choice. That is the Food and Nutrition Service under the U.S. Department of Agriculture. They procure that. There are only 2, so every state has to pick one or the other. And there have been problems with both in terms of the kind of back-end technical side of implementing these chipped EBT cards. So we would like to get there very much, but we do need the appropriation to do it. And then we need some of this other technical stuff, which is not anybody's issue here in Pennsylvania. They have to fix that. Some of that stuff has to be resolved. So in the meantime, we have taken steps to give folks more flexibility in terms of how they manage their own cards, and that is by enabling this lock feature, and people can lock and unlock their phones. They can decide or they can designate if they want their card to be used out of state or not, like if they never purchase anything out of state, they don't order from any place, or they don't live near a border. They can turn that feature off. Gives them a lot of flexibility, and we are seeing people lock and unlock their cards now routinely.
Thank you. Thank you, Mr. Chairman.
Thank the gentlelady. Representative DeVanzo.
Thank you, Chairman Harrison, and thank you, Secretary Kush, for being here today. Madam Secretary, your budget includes funding through the Keystone of Health Section 1115 waiver to provide Medicaid coverage for individuals up to 90 days prior to release from prison, including services such as medication assistance treatment that are currently funded through the Department of Corrections. It also proposes using Medicaid funds for housing-related support, such as rent, moving expenses, furniture, even purchasing pots and pans for individuals without stable housing. Medicaid is intended to provide health care for our most vulnerable population. Do you believe it is appropriate and fair to use Medicaid dollars for rent and household goods for individuals leaving prison?
Representative, I think we've been talking all day about really important changes we could make to the Medicaid program in order to help reduce the spend in Medicaid. And, Medicaid was designed in 1965, and if you gave me a blank sheet of paper today and asked me to start a Medicaid program, I would start with food, housing, and transportation. because these things are essential to being healthy. So when it comes to the reentry program, these are proven programs that will reduce recidivism and reduce overall costs for DOC, most importantly by reducing recidivism. They've been shown to reduce overdose deaths. They have been shown to reduce emergency room use once someone has been released. And that is all because there's been stabilization on medications, there's been careful planning before release, there's prioritization for housing, and prioritization to get people connected to job training and have a driver's license, have all their documents, all those places where people fail when they reenter their communities. Our goal is to set people up for success and have them not ever have to come back to the DOC. And so when it comes to moving expenses and things like that, I know that that is written in the grant. As a matter of actually implementing this grant, Medicaid is always the payer of last resort, and things like we need to be helpful in getting them housing. You know, although an individual has paid their debt to society, very few landlords accept that that debt has been paid and are very reluctant to rent to someone who's been incarcerated. So we need to provide some assurances for that. But when it comes to things like furniture and other household goods, our goal would be to look to community-based organizations to provide those things. And I would imagine that it would be only the rarest of circumstances that we would help provide someone, you know, with a mattress to sleep on if there was literally no other way for them to get one.
Yeah, thank you for that answer. And you know, these dollars got to stretch. And it sounds like a very efficient program, which leads me into my next part here. Governor Shapiro has repeatedly stated that he will not cooperate with ICE. So my question is, with what additional safeguards are we putting into place to ensure that our Section 1115 benefits are not going to go to illegal immigrants who may be released here from prison?
Our Medicaid program does not enroll anybody who is not eligible for the Medicaid program, and someone here with no status or is undocumented is not eligible to enroll in our Medicaid program.
Yeah, I just know that we heard similar statements from the Department of Transportation. Just within a year, we had two illegal immigrants, get CDL driver's license, and it resulted in a deadly accident. So,
yeah, but
just
as
trying
you
to get
know,
ahead of it.
Representative, that's because the federal database was wrong.
Yeah, but those folks were put in under the Biden-Harris administration. So our President Trump is trying to clean it up here. So thank you.
Haven't done it yet.
Representative Donahue.
Thank you, Mr. Chairman, and thank you, Secretary, for being here today. In our current budget, the General Assembly included funding to increase the early intervention rates. Could you just give us an update on the progress of that rate increase?
Sure, yeah. So this is something that was long needed and welcome, very welcome by our early intervention community. As you know, providing early intervention services is really the best investment we can make. The earlier we intervene with a child, the greater the chances are of just lifetime success from those interventions. So the 25-26 budget did put in the increase for rates for this group. That increase will be retroactive to July 1st, and those providers are probably just starting to see that now because of the delay in getting the budget completed. And then in the 26-27 budget, that increase is fully accounted for. I know that the budget as written does show a decrease in those rates, but that is because we had some carry forward dollars that we were able to use. So the actual budget line looks like it's a reduction, but the full increase is carried forward and annualized.
Great. I was going to follow up with, was it retroactive too? But given that the 2024 early intervention rate methodology study found that infant toddler early intervention rates to be underfunded by $71 million, does DHS have a plan to address the rate disparities in the program moving forward to ensure that eligible infants and toddlers can be served by this federally mandated program?
So we are constantly evaluating rates and constantly evaluating access to services. And as you know, we are faced with a number of very, very difficult choices as we look at our budget, and we're just doing our best to balance needs. We are, at this juncture, there's there's network adequacy across our providers, and people are getting services. And so, again, it's just something that we keep a very close eye on, and we will certainly lift it up if we believe that it is essential that an increase happen, as we did last year.
Thank you for that answer, and I just want to say also thank you for your work on Representative Kincaid's question on SNAP benefit fraud, because that's been a big issue in my district as well.
Yeah.
And it really does break your heart when you have moms and seniors coming into their, their cards get filled at midnight, and by 7 a.m. it's all gone, and that's their food for the month. So thank you for your work on that. It is,
Thank you.
I wish we could do it faster, but there are different considerations that have to be taken into effect.
Hopefully,
there,
we
but
can do it responsibly together, I hope.
Thank you for that.
Thank you.
Thank the gentleman, Representative Krupa.
Thank you, Mr. Chair, and welcome. Thank you for being here. Madam Secretary, our Commonwealth has seen horrific cases of child abuse. The last few years have really hit Fayette County hard, and it's left our community heartbroken, but also outraged. Renesmee Utsi was found dead after being starved and tortured by her guardians. 5 children were discovered locked in dungeon-like conditions in Redstone Township. Starlyn, who was confined to a cage in her own home. These tragedies will not be forgotten, and these are just a few. These awful cases of abuse have led to many questions from members of the community about how the oversight of county children and youth systems actually work. And I have a few questions, and please, just to be extremely clear, I am not implying that the Fayette County Children and Youth did any wrongdoing associated with these incidences. I just know that these particular cases led me to dig deeper into the children and youth systems and potential deficiencies in oversight. Right now, complaints against county child welfare agencies are handled by the Department of Human Services itself. Madam Secretary, the fox cannot guard the hen house, and I believe that Pennsylvania's children and families deserve better. I believe that we need an independent office of child welfare ombudsman or child advocate. I don't care what we call it, as long as it's empowered to independently investigate complaints, publish reports, and hold the system accountable. I think it needs the teeth of subpoena power. So with respect to the current system, when serious failures occur within a county children and youth agency, particularly in cases when a child is severely abused or killed, who conducts the review of that agency's actions?
Well, first of all, let me just say that those are heartbreaking cases.
Yes.
And nobody wants to see that happen anywhere. And again, just a reminder that child welfare in this Commonwealth is actually run by counties. I know this well. I was a county commissioner for 8 years, with oversight from DHS. And so it is actually the county who should be directly accountable when you think about what is happening in any particular county. But we work very closely with them. We provide them support, everything we can to assist with them. I think the other point that's really important here is that we pretty consistently in the Commonwealth have between 55 and 60 fatalities every year. And every one of them is heartbreaking. But our child welfare systems, and this has been consistent year to year, typically only know about half of those families or children. Every year, half the children that die, there's been absolutely no contact with any kind of children and youth agency, no report to Childline, nothing. The first contact is tragically at the death of that child. So we have been undertaking over the last year some conversations about just pulling back and taking a holistic look at what can we do to keep kids safe. Child welfare is everybody's responsibility. You know, what I see, somebody calls child welfare and they kind of wash their hands and say, okay, I did my job, but it cannot be that way. Everybody in every community needs to be responsible for helping to keep kids safe. And that is what we hope can make a difference. Diverting cases that don't need to be in child welfare, that just need some social services support to that, trying to prevent as many of these types of instances as we possibly can. That is where we're going to start to change this trajectory.
And I led with some specifically horrific cases, but a lot of the complaints that we hear about children and youth are cases that, by the grace of God, don't reach that element of just plain out horror. I don't know any different way to say it. So in situations where a parent or a foster parent or a community member believes a children and youth agency mishandled a case or is mishandling a case, what truly independent avenue exists for them to file a complaint and have it investigated outside of the department and outside of that county agency involved?
Well, I will say that people do reach out to us from time to time, and our staff can conduct investigations of what transpired in a particular case. And there are situations where, in specific cases of abuse, if there's an obvious conflict of interest at the county level, then we have somebody from our regional offices actually conduct the child abuse investigation.
So my yellow light is on now, but I have to ask, what is the agency doing then to be transparent with these findings, to report these findings, and really to hold the county agencies to the fire with respect that they're doing everything in their power to protect our children?
Yeah. So we publish an extensive report every year. And there's detailed information about every single county and who has completed all their investigations, who's behind, what the results of all those investigations were. All of that information is publicly available. And we're moving toward the day when we have dashboards that are much more real time. Like, we're very much hoping to increase the transparency around all this work. Again, to getting to that point of keeping kids safe is all of our responsibilities. And we hope that we can continue to bolster this system.
My time is up. Thank you very much.
Thank you.
Thanks, Gentlelady. Representative Mays.
Happy Women's History Month. Thank you, Chair. Thank you, Secretary Arkush, for being here today. I have lots of questions, so I'm going to move fairly quickly. Thank you for your continued support of the Pennsylvania Black Maternal Health Caucus. As co-chair of our caucus, I want to talk about the Pennsylvania Momnibus legislative package. In the first version of our Pennsylvania Momnibus, we were able to introduce 8 bills, pass 5 out of this chamber, and 2 became law, including Medicaid coverage for doula services. So I just wanted to ask you, Secretary, what has been the impact of covering Medicaid services, and could you talk to us or give us a quick update about the Doula Advisory Board that also was codified into law?
You bet. So the Doula Advisory Board has met. We are meeting quarterly or 3 times a year. I can't remember. It's either 3 or 4 times a year. And we did get some recommendations from all of you. So we had a first meeting. It was great. A lot of information sharing. And we followed up and reached out to get a better understanding of what the folks on that advisory board want to talk about, what data they'd like to see from us. So we're really excited to have that opportunity to meet with folks. And I have some just great news. We're making really good progress with the doulas. As of, I believe, the first of the year, we've got 299 certified doulas.
Wow.
So as you remember, the first step to becoming enrolled as a provider is to become certified. That is a process that we've made it so that it's cost-free to individuals. The doula associations worked with us on that. So we're now up to 299. And as of February 18th, these are late-breaking numbers, we have 155 unique certified doulas serving medical assistance beneficiaries at 240 service locations.
Wow.
So it's pretty exciting.
That's
yeah,
great
we made
progress.
really good progress.
Thank you so much, Secretary. And we know that doulas can be a great intervention around maternal mortality and morbidity across the Commonwealth. And so I want to actually build upon the questions from my colleagues. As we have been able to work in a very bipartisan way to advance maternal health and Black maternal health in the Commonwealth. And so my question is actually about rural communities, because some of the same interventions can help urban communities like mine. So my question is about the Rural Health Transformation Program. And if you could share more about the types of strategies that rural communities can utilize through this program. I'm thinking about telehealth services. I'm thinking about remote monitoring for blood pressure. I'm thinking about mobile units that go to our more rural counties. I'm also thinking about partnership with our federally qualified health centers. And of course, building the pipeline of the perinatal workforce of doulas and of midwives. And we've seen some traction in the General Assembly around creating greater access and giving more practice authority to midwives. And so could you talk about how those strategies might be ways for us to invest those rural health transformation dollars?
Yeah. So I appreciate the question. I'm going to start with the workforce piece first. One of the things that we're very excited about is that in June of 2025, Pennsylvania became the first state to obtain a registered apprenticeship for doulas. So it took a lot of work to get there, but there's a whole now codified set of apprenticeship trainings and educational pieces. And that, of course, would allow someone to be paid while they're training. And so we have funding, we could potentially have funding through the rural health dollars to help fund an apprenticeship program that is training doulas who will commit to working for 5 years in a rural community. So that's one way. And then there's many other dollars in the RHTP for training all levels of providers, as long as there is that commitment to practicing in a rural community for 5 years once that training is done. And then to your earlier point, all of those items that you listed absolutely can be covered through RHTP. These are the types of things, I mentioned this morning, we can't give money to help hospitals with their operating expenses, but if a hospital wants to purchase a mobile van and make sure it's tele-equipped with ultrasound and all of it, we can do that. And that can go out and take care to where people are. We know that is so important. Transportation is one of the biggest barriers, particularly for rural pregnant people to get care. We can do all kinds of remote monitoring, whether it's for uterine contractions, blood pressure, all of it. So I think there's a lot of thinking going on right now about how to take advantage of these dollars to create these programs.
Thank you so much, Madam Secretary. Hopefully, if time allots, I'll be back for more questions about child care. Thank you.
Thank you.
Thank the gentlelady, Representative Barton.
Thank you, Chairman. Welcome, Secretary Arkush and Team Human Services. And Madam Secretary, the governor's proposing to raise the minimum wage to $15 per hour on non-tip workers effective January 1st of 27. The capitation appropriation includes $12.5 million in savings from decreased enrollment and conversely $2 million in costs to the Children's Health Insurance Program, which reflects the transfer of children from Medicaid to CHIP, right? So can you provide details on the number of individuals who will no longer qualify for Medicaid and the number of children who would transfer to CHIP?
Gloria would be happy to give you those numbers.
Thank you.
So over the course of 26-27 and 27-28, we'll have 60,800 individuals who will come off of the Medicaid rolls, and on to CHIP should be about 19,000 children. So of that 60,800, 19,000 are children who will transition to CHIP in our assumptions.
Thank you. And if I could just follow up on the child care services and child care assistance line items include $2.7 million in $2.7 million in recognition of increased service costs associated also with the proposed minimum wage increase. Now, according to the official House fiscal note, during the passage of legislation increasing the minimum wage in June of 25, the increased service cost to Community Health Choices appropriation would have been approximately $88.4 million for fiscal year 26-27. Why do your department's budget materials not include any estimated impact to the CHC line item to account for this proposal?
So, great question. So when you look at child care providers, the data that we currently have is that the average child care worker in the Commonwealth right now is making about $14.90 an hour. So we explicitly put in dollars for that. When you look at individuals who are providing personal assistance services in our Community Health Choices waiver, that the managed care organizations get, and you have one of these on your desk, so I will spare you the details, but when we do the annual capitation rate setting process, we account for things called trends, and one of the things that we account for in that is things like where wage rates are likely to be in that next calendar year. And for that, we use Bureau of Labor Statistics and other national databases. For the BLS data, we actually use their Pennsylvania-specific data. And according to that data, that group of workers by January of 2027 should be at $15 an hour. And so we put that into the trend for the capitated rates. A year ago, that trend did not have them at $15 an hour, and so it would have necessitated separate additional funding to get them to 15. But now, by 2027, the trend, the BLS trend, is that those folks will already be at $15 an hour or will be at 15, and so that's taken into our capitation cost.
Okay. So let me ask you this. Are there any other budgetary impacts to this proposal that were not included in your materials?
Not that we're aware of, and as you know, it's a net savings of just under $50 million.
And Secretary, I didn't mean to walk over you there, but would there be impacts at the county child welfare staffing level as well?
No. So, no. I mean, that's, the counties set those wages. Every county is a little bit different, and that is done through the needs-based budget, and we don't have any indication that that would necessitate additional funding in that line.
Okay. Thank you very much.
Thank the gentleman. Representative Webster.
Thank you, Chairman, and Dr. Arkush, thank you, and your team, especially for your endurance today. It's a long day, and yet, as we all know, there's so much more that you and we are responsible for in this regard. We've already touched base on a number of issues around the rate reimbursements, whether it's early intervention or brain injury, mental disabilities, those kinds of things. I'm going to kind of push back into the combination of maybe rates, reimbursement, and the services and sustaining those services, and maybe traumatic brain injury is the easiest one to focus on. But the combination of how the increase in rates allows us to provide services and programs, and how do we sustain them when individuals need that kind of continuum of care and to proceed.
I'm not sure
I
totally understand the question.
So reimbursement rates add up, right? They're meaningful for our providers. Sometimes programs are too short, and a person with an injury or a disability, graduates before they. I'm talking about both the policy and the rates.
Right. Well, I mean, I think these are the tensions that our programs live under every single day, right?
Yeah.
We need to be very careful stewards of taxpayer dollars. We are appropriated a budget by all of you that we do our absolute best to live in, even acknowledging that these are entitlement programs, and so whoever's eligible does get enrolled, and making sure that we make best possible use of every one of those dollars. And so we do go through this annual capitation setting, that you have some description of that in front of you. And we do our best to look back and look forward and account for trends, to account for increasing costs. And many years, when our MCOs are given their initial contracts, we do go through a negotiation period with them. This year we did not, because we were giving them our best and final offer. But we are always willing to hear from them if they believe that we have really overlooked something as we were doing those cost calculations. So again, it's doing our best to balance what are completely divergent interests. Everybody wants more money, but nobody wants to appropriate us more money. And so this is where we live every single day at DHS, is trying to balance that. And our first and foremost goal is making sure the people that we serve have what they need, and we make every decision with people at the center of this, and we do our best.
Can we go back, like if the waiting lists have been reduced or eliminated, but the length of our programs for success?
Yeah, I mean, I think that you may be alluding to the adult emergency waiting list for individuals with intellectual disabilities and autism. I'll just use that as an example.
Right.
You know, that was an initiative that the governor made a commitment to back in 2024. And since that time, I am just thrilled to say that that list has been reduced by 31%. And, but that happened with a combination of two things. The General Assembly was supportive enough that they appropriated additional funding for additional slots in those programs. And in fact, the governor has a second request in this year for additional slots. And simultaneously, we moved toward giving counties flexibility that they had been asking for years to manage to a budget rather than to these discrete slots. And so just to give you an example of the impact, the first 3 counties that moved over to this budget approach with lots of support from my team, they were able to add 59 people across those 3 counties to these, I think it was probably mostly the community living waiver, because they were able to give folks the services they needed right then, and if they didn't need every single service in that waiver, they could bring an additional person on that sort of budget and provide maybe 2 people services, someone who didn't need very much and someone who needed a little bit more, and make it all work. So we were able to get an additional 59 people in. So that's a very tangible example of how we're looking at every one of our programs and figuring out how can we make the best possible use of every dollar.
Appreciate it. I know that you and the team, as professional as we have in this Commonwealth. Thank you much.
Thank you.
Thank the gentleman. Representative Marcel.
Thank you, Mr. Chairman, and thank you so much for being here, Madam Secretary. I have 2 questions. The first one has to do with the amount of supplemental security income funding, and specifically the personal care boarding home supplement that Pennsylvania provides to low-income seniors residing in personal care homes. Since 2021, more than 110 personal care homes that cared for low-income seniors across the Commonwealth have closed because of SSI funding issues. As a result, in the past 5 years, more than 1,000 low-income seniors have been displaced from their homes. So I was wondering what can we do to help slow that, the closures? And then also specifically, if someone cannot go to a non-SSI personal care home, do you have any data about where they do go? Is it a skilled nursing facility? Eventually, would they end up at a homeless shelter? Like what happens to them after that? Thank you.
Yeah. So I'm going to answer the second part of your question first. So by definition, somebody who goes into a personal care home does not have the needs that would make them eligible to go into a nursing facility. That is a very defined set of clinical conditions, and so you would not go into a personal care home. Personal care homes really provide care for people that have very minimal needs in terms of supports. So those are sort of 2 very different populations. So we are very aware of the situation that some personal care homes are facing now, those that do take SSI recipients. That subsidy has not been increased since 2022, and that is something that is entirely state dollars. And so again, if the General Assembly would like to bring forth a proposal around what that would look like, I'm sure everyone would be happy to take a look at it. It is, again, another thing on the list of in a very tight budget. Where does that fit in on the prioritization list?
Thank you.
So,
I do appreciate that.
Yeah.
And yeah, I understand. Obviously, we have a lot of different areas during this entire budget process that we're examining, so I appreciate that. And then I did want to turn to talk a little bit about back in December, the vendor who several Commonwealth agencies worked with that had problems with the mail. I know there were a lot of issues surrounding that. And I was wondering, I appreciate that a lot of departments were extending deadlines and trying to help with that, but I was wondering if you could tell us, from a fiscal perspective for your agency, how much did that issue cost to correct? And then will this type of delay have any impact on the Commonwealth's error rate?
So as you, I'm sure, are very aware at this point, that was a contract that the Department of General Services held with a vendor. And when they came to pick up our mail every day, to us, that was no different than putting a piece of mail in the mailbox. And so we were quite surprised to learn that they had not been sending mail during that period of the budget impasse. And I think the vendor's been pretty open about the fact that it was due to lack of payment during the budget impasse that they stopped sending mail. So for our agency, it was 1.7 million pieces of mail. We have incurred a number of costs. We have, as you noted, we extended deadlines where we were allowed to by federal requirements. We have had to reschedule 1,333 appeal hearings because people were not notified timely, but we are working through all of that. And in the sort of short-term moment, we have incurred over $250,000 of unplanned costs around mailings, but it is going to take time for us to determine the full cost of this delay, and that relates to the fact that we have a lot of people that need to go through appeals and that whole process. And so our intention is to take every action possible that is available to us legally to recoup whatever that final cost ends up being. But I don't have that number yet. It's going to take us several months before we know.
Thank you. And so later in the year, perhaps you could give us an update on how that's going and those additional costs, just so that we're aware of it. And then just to follow up, is there could that impact the Commonwealth's error rate?
Yeah, so as we talked about earlier, there are many factors that can increase that error rate. We are, happily, as of October 1st, we're under 6%, and we very much hope to stay there. But it is, this is one factor that could potentially impact that.
Okay, so that failure could actually make the error rate go up, is what you're saying?
It all depends on how some of those cases are ultimately, yeah, so I can't really answer it yet. Is it in the realm of possibility? It is.
Okay, thank you very much. Thank you, Secretary.
Thanks, Gentlelady. Representative Guzman.
Thank you, Mr. Chair, and thank you, Secretary Arkush and your team for your time this afternoon, and of course, for your work on behalf of all Pennsylvanians. I'm going to ask you, if you can, Secretary, to please be as succinct as possible in your answers. But in my work as state representative, I hear a lot from working families in my district about the challenges that they face, whether it's keeping healthcare costs down, whether it's ensuring that poor kids have access to insurance, and/or whether it's making sure that when they get sick, somebody takes care of them. Unfortunately, in our political rhetoric, whether it's politicians in Harrisburg or in D.C., they have repeatedly blamed poor people and migrants for the challenges we face in our healthcare system. In fact, during the big, beautiful bill budget debate, the president repeatedly made false claims, quote unquote, saying that Democrats want $1.5 trillion for healthcare for illegal aliens. And so I'd like you to answer these very specific questions, Secretary Arkush. And is it true that are undocumented immigrants eligible for Medicaid?
Only in one very specific circumstance, which is emergency Medicaid, if they show up at a hospital with or other care site with an emergency condition.
Are undocumented immigrants eligible for Medicare?
I don't believe so. That's not my area, but I don't believe they are.
Are undocumented immigrants eligible for ACA credits?
No.
Are undocumented immigrants eligible for EBT or food stamps?
No.
In your expertise, are immigrants living in the country illegally prohibited by law and statute from receiving any federally funded coverage?
Again, with the exception of emergency medical assistance, they are prohibited.
And let's focus in on that emergency medical, because it was a Republican president, Mr. Ronald Reagan, who signed that bill into law, who talked about our shared humanity in terms of making sure that folks who don't have access to insurance and/or whether or not they're undocumented are able to go to our hospitals for care. And so let's go down that rabbit hole, Secretary Arkush. Do you believe that someone who has a heart attack, whether they're white, black, or brown, and they don't have insurance, do you believe that that individual, if they go to the hospital and they don't have, if they're undocumented, do you believe that that person or individual deserves access to health care?
Well, I'll speak as a physician. Of course I do. And I will tell you that when I was practicing, we didn't check anybody's insurance card at the door. So whoever showed up, we took care of them.
Do you believe that somebody who has a brain aneurysm, whether they're white, black, or brown, whether they're undocumented or not, and doesn't have insurance, and they show up to a healthcare facility in our Commonwealth, do you believe that they deserve access to health care?
I do.
Do you believe that somebody who has a life-threatening medical emergency and is white, black, or brown, doesn't have insurance, and/or is undocumented, and they show up to a hospital anywhere in our Commonwealth, do you believe that they deserve access to health care?
I mean, certainly in an emergency situation, yes. If it's something that is not an emergency and they could be handed off in a warm handoff to like a federally qualified health center, something like that, I think we should go those routes. But in an emergency, I think we need to provide that care.
So let's talk about let's drill down exactly what we're talking about. We're talking about some politicians in both this building and in DC who don't want our neighbors to, when they have, whether or not they're having a heart attack or they're having a stroke, whether they're white, black, or brown, and of course they don't have insurance and/or they're undocumented, there are some politicians who are zeroing in on the fact that individuals that are sick, that are potentially dying, should not be able to go to a hospital to get medical treatment. Is that a correct assessment?
I'm aware that some people feel that way.
So what do you say to politicians both in this building and in DC who have this type of rhetoric, who's saying that immigrant individuals, when they're dying, when they're literally at death's door, and they're asking whether or not hospitals should be asking for immigration status when they're literally at death's door? What do you say to politicians in both this building and in DC who make those type of claims?
I think there's two parts to that answer. There's the moral and ethical framework that healthcare providers practice within. Many of us have taken an oath to always put our patients first and intend to uphold that oath every single day. And so it would put providers under incredible moral hazard to try to make those sorts of decisions in real time when someone is literally in front of them dying, potentially dying. And then the other part of this decision-making is our hospitals. You know, we spent the whole morning talking about the precarious situation that so many of our hospitals are in. The hospitals under EMTALA in this country are required to treat emergency patients no matter what. And so if they cannot be compensated in any way for that care, then it only furthers the precarious situation that our hospitals find themselves in.
And again, I know my time is wrapping up, but these are our friends, family, neighbors, their workforce. They're in our neighborhoods every single day. And then when you have certain politicians who say that based off of your immigration status, you shouldn't receive health care at all, that is a moral hazard for all individuals who serve in government. Thank you very much.
Thank you.
Thank the gentleman. Representative Kale.
Thank you, Mr. Chairman. And I wasn't going to go down this line of questioning, but I think it's necessary after what we just heard. You know, in Harrisburg and in politics, far too often, we don't talk to each other. We just talk at each other or over each other. Madam Secretary, the question that many on my side of the aisle have, whether it's here or in D.C., is not whether or not these illegal immigrants are eligible for these benefits. The question is whether they are receiving these benefits. So the question I'm going to ask you here in a minute or right now is, what are we doing to ensure that we are actually following the federal law that they aren't receiving the benefits?
Well, I can only speak for Pennsylvania's programs, our Medicaid and our SNAP program. But as we talked about this morning, our team checks 15 databases, cross-checks them, and if there's any incongruity in the data that we get from those databases, we go directly to the person to get final documentation and proof in actual documents. And we do not enroll people who are not eligible for these programs. People who are here without any legal status are not eligible for these programs.
So you're checking the immigration status for these
We check
programs.
all of it, yeah, multiple databases.
Because my understanding of what happened in Minnesota wasn't that these individuals were eligible for these benefits, is that they were taking it fraudulently. And that's the problem that we raise on these issues. Now, additionally, there was federal changes to these things in H.R. 1, the big, beautiful bill. It's been talked about quite a lot. Were there any changes to the eligibility as it relates to the emergency exceptions that you were talking to in Medicaid, as it relates to the eligibility of it?
Yeah. There are. But I just,
so
I'm
illegal
sorry,
immigrants
I just
are no
have
longer
to go back
eligible.
to Minnesota, and I don't want people to conflate these two things.
Illegal
Minnesota was
immigrants-
about child care providers, not eligibility in programs.
I have moved on
What
to the next
HR
topic.
1 has done.
Everybody
in
will
terms of,
suspend. Hold on. We're not going to talk over each other. We're going to give everybody an opportunity to respond. So we're going to let the secretary respond, and then Representative, you'll have an opportunity to respond. We'll give you a little latitude because she wants to give a full answer, so we'll do that.
Thank you, Mr. Chairman.
Secretary?
So specifically around HR 1, what is changing is that certain refugees, asylees, people here on certain humanitarian parole visas, There's a number of categories of individuals who have been able to be legally eligible for Medicaid. H.R. 1 is taking that away as of October for the 1st. So those folks today legally are eligible for our programs. They will not be after October 1st, and that will further contribute to the number of uninsured individuals here in the Commonwealth.
So that list of the answers to the questions that you just heard from Representative Guzma then was actually incorrect, because you said they're still eligible. You said illegal immigrants are still eligible for these emergency benefits.
Okay, maybe I misspoke. They are, undocumented people are eligible for one thing and one thing only, and that is emergency Medicaid if they have an emergency.
Emergency Medicaid.
These other folks that I mentioned who are here with legal status but are not legal permanent residents, asylees, refugees, people in those categories, they're currently legally allowed to have a regular Medicaid enrollment. But after October 1st, they won't.
And I'm talking about illegal immigrants here.
Okay.
Because we just had a conversation about how Republicans want to get rid of that status for illegal immigrants in that emergency exceptions, yet Republicans in D.C. who have control of the United States House of Representatives and the Senate and passed sweeping legislation as it relates to benefits, and they didn't change that. That exception is still in the law. So here we are just talking back and forth to each other about something that is completely irrelevant. And it gets very frustrating because I get painted a certain way, our party gets painted a certain way, because there is propaganda coming from the other side on these issues. It's just something that is frustrating in the body politic as we see it today. I'd like to move on to my next set of questions.
There is one change that is going to have a budget impact for us, which if you would like, I would share with you. And that is that the federal match for illegal individuals who are getting emergency Medicaid, who are eligible for that system because of Medicaid expansion, the FMAP, which was at 90% or is at 90% today, is going down to regular FMAP.
And I specifically asked about eligibility.
That is going to be an $18 million hit.
Mr. Chairman, if I could get a couple more minutes. I specifically asked about eligibility. The funding, how the feds work through the state and all this other stuff, I'm concerned about eligibility. I wanted to ask briefly a question. You know, Pennsylvania's population is getting older, and we see that all over the Commonwealth, in particular my area. And nursing homes are something that, you know, we're seeing less and less of them. Does the administration have a plan for over the next 5 to 10 years of how we can handle this growing and elderly population as it relates to nursing homes and any other way?
Yeah, I mean, we talked about that this morning. Maybe, I'm sorry, I don't know if you were here this morning, but we have been extremely successful in giving older adults the choice of where they want to age. And if they're eligible for a nursing home level of care, they can choose to go into a nursing home, or they can choose to have home and community-based services, which are less expensive than a nursing home. And we have seen our older adults really vote with their feet, and the vast majority are now choosing to stay in the communities that they love, often in their own homes, and age in place. So while our older adult population absolutely is growing, we are not seeing those folks choose to go into nursing facilities. And in fact, the number of people in the Medicaid program, at least, that are in nursing facilities has dropped substantially over the last number of years because people are choosing to stay in the community. But separate from that, there are a number of programs. I talked about one that Department of Health is running to improve quality in our nursing homes. It's been very successful. We have pay-for-performance funds within our Community Health Choices programs that are tied to quality of care in nursing facilities. So there are programs like that ongoing, but we are about consumer choice, and consumers are choosing to stay in the community if that's a possibility for them.
Thank you, Madam Secretary. Thank you, Mr. Chairman.
Thank the gentleman. Representative Waxman.
Good afternoon. Thank you so much for being here and your whole team. It's really great to be able to get into some of these conversations. Wanted to ask a little bit about some of the new regulations that have come down from the federal level and how they're going to impact our vulnerable populations here. And some of this, I think, was covered a little bit earlier, but I want to go through it. Most people who get their health insurance through Medicaid here in Pennsylvania, their children, They're people with disabilities, pregnant people, seniors, and then the remaining 700,000 or so, these are low-wage workers who access Medicaid through Medicaid expansion. And so these new work requirements, which is what they're called, they're really just kind of a lot of bureaucratic red tape. What is the department doing to make sure that everyone who is eligible gets coverage and doesn't lose it because of these new rules?
Yeah. Well, for Medicaid, this is the first time ever that there's been any kind of community engagement requirement. That's the official name in HR 1. So working, volunteering, or being in school at least half-time. And we, of course, had to start with SNAP because the SNAP deadlines, it's already begun. But Medicaid will start in January. And along with that, in January, that same population, which is about 760-some thousand people right now, will also have to redetermine their eligibility every 6 months. So it is a lot of increased red tape for these folks. So we've already built a number of systems for the SNAP population that will be available for all the Medicaid population, online tools. We're asking all of you to please help us spread the word. We have a whole page of resources. We have a Substack. We have social media. We've got all that. We have a whole group of people that it starts to meet tomorrow that we hope will also help be our boots on the ground to help get this word out and help advise us. And then we're doing things on the back end. So we are looking at individuals who, and we've been able to do this in SNAP, who are in both SNAP and Medicaid, and we can tell from their claims data in Medicaid if they have any of the legal exemptions to the work requirements for SNAP, and then we will just automatically make them exempt, so they don't even have to do anything. The challenge we're facing in Medicaid is that we still do not have all the information that we need from the federal government for what is going to be considered an exemption for Medicaid work requirements. There's something called medical frailty that has yet to be defined. Administrator Oz and other folks at CMS have told us they are going to provide us with that definition. Unfortunately, it's already March, and we don't have it yet for a program that we have to start implementing on October the 1st, because that's when the notices have to go out for January. And we've been told we'll get this information by June, but June is awfully close to October. And so we're really starting to get nervous about the fact that we're going to be asked to make changes in this program, and we don't even know what they are yet.
So new requirements have been put in place, and then the information that is required to implement those new rules has not been forthcoming from the federal government.
That's correct.
Okay. It sounds like it's a combination of things. I mean, I appreciate you going into the SNAP. That was part of my question of how you're dealing with it with SNAP. I appreciate that. It sounds like it's like more staffing, more technical IT, to be able to do what you need to do. I want to ask a similar question around one of the big beautiful bill, as it's called, made cuts to state-directed payments. These were funds that were distributed as incentives to get healthcare providers to take patients with Medicaid insurance. How much do you think it would cost the state to backfill those Medicaid provider incentives?
All right, I'm going to talk while Gloria tries to look that up. So the state-directed payment, there's a specific way that they're going to be cut. Right now, let's talk about a hospital. They get their Medicaid payment, but then we are often also able to give them an additional state-directed payment, and it's related to quality measures and other things, but also to maintain access. And that payment, we can make it such that their Medicaid payment plus the state-directed payment gets them up to something like an average commercial rate, meaning what your average commercial insurance plan would pay. So that is really meaningful for these hospitals. The HR 1 bill caps it at Medicare rates. Medicare rates are slightly better than Medicaid, but they're still not anywhere near average commercial rate. And so that is going to lead to
about a $2 billion reduction in state-directed payments over that 10-year period, starting in calendar year 2028.
Very significant.
Very significant.
Very significant. Okay, those are my questions. Thank you so much. I really appreciate your time.
Thank you.
Thanks, gentlemen. Representative Alsamer.
Thank you, Mr. Chairman. Madam Secretary, my question is regarding GLP-1s. Specifically, it's my understanding that your department is no longer providing coverage for costly GLP-1 medications like Ozempic. effective January 1 of this year. What is the anticipated cost savings of not covering these GLP-1 medications?
So I just want to clarify, we continue to cover GLP-1s for many indications, and if we have only stopped covering them in adults who are taking them only for weight loss. Okay? And the savings is, okay, so the savings for this year, because remember our MCO contracts are in a calendar year. So the savings for this year are total $348 million, of which $112 million are state. And then the annualized that we have in the 26-27 budget is $836 million total, of which $266 million is state.
Has the department calculated to what extent individuals who receive GLP-1s for obesity will continue to receive them through an alternative, eligible diagnosis such as sleep apnea? So in other words,
Right. Yeah. So we're only stopping coverage for individuals who are only taking it. So they don't have diabetes, they don't have sleep apnea, they don't have heart failure, they don't have a very specific liver condition, things like that. And so we have made our best estimate of the number of people that is. We do not, our drug claims don't actually have diagnosis codes on them. So we have to look at sort of the other part of a chart for all intents and purposes. So we've made our best estimate. We think that's about what the number will be. It could be higher, it could be a little bit lower.
do you have a number, or do you have an estimate of the number of people who keep that coverage and are on an appeals process?
I don't have that number now. I mean, there could be people who are appealing, but
Yep.
I don't have that in front of me.
Is that something?
But there is an appeal process.
Yeah, is that something you could follow up with, or is that not yet available?
So it first goes through their managed care organization,
Mhm.
and so I don't know if we could, how quickly or easily we could get that.
Understood.
Yeah.
Has there been any consideration about a lot of these manufacturers have gone to a pill? And I'm wondering, I know the cost point on those pills have come down significantly, and I'm just wondering what the department's position is on those.
Well, we're watching that very closely, and so far, only one company has had a pill approved that, at least the kind of modern pill approved that I'm aware of. And when we looked at the pricing that would be available to us, because we do participate in a Medicaid rebate program, which is a pretty robust program, the cost of the pill, the one pill that's been approved so far, is actually more than the injectable. And so we have actually issued a bulletin saying that if you qualify for a GLP-1 for any of the approved indications, that you must start with the injectable unless you have a contraindication like you're anticoagulated and you can't take a shot. So I know that there's at least one other pill that is very close to approval, and so we'll see what that price point looks like.
Okay. Thank you very much. Thank you, Mr. Chairman. Thank you.
Thank you.
Thanks, gentlemen. Representative Bellman.
Thank you, Chair, and thank you, Madam Secretary, for being here. As your department is aware, I have legislation that would reduce the number of justice-involved youth in county detention awaiting placement or that are placed in secure treatment. It is likely to reduce costs for local and state government. This legislation passed the House in February and is currently awaiting consideration in the Senate. And I know that DHS has made efforts to reduce the amount of time that justice-involved youth wait for placement in secure treatment. Can you just talk a little bit about the efforts that you've made over the past few years?
Yeah, you bet. And first of all, I would just like to thank you for working with us on that legislation, and we're really happy it's made it through this chamber, and hope it will get through the
Bipartisan support too. So
That's right, I know.
That's right.
Yeah, this should be bipartisan issue, right? So when we all got here in 2023, there was a considerable waiting list for youth who had been adjudicated to treatment in one of our secure DHS-run facilities. The waiting list at the time was around 175 youth, and there was a considerable delay in some cases in getting those youth into treatment. We have worked very hard to expand the amount of facility beds available, treatment beds available, and again, with the support of the General Assembly, which we're very, very grateful for. And we have opened a new, actually more than one at this point. We've expanded some and opened a new one. We have repurposed some existing ones for youth that have longer periods of stay with us. And I'm very happy to tell you that the waiting list is now down to anywhere from 9 to 15 youth on any given day, and we are typically moving youth into placement in less than 2 weeks.
That's awesome. And I know you said a part of the effort was to add capacity. So the new Southeast Treatment Unit opened in July of 2024. Can you provide an update on how the facility is currently doing and what's the current capacity for that facility?
Yeah. You know, this is a great example of working across agencies. This was an empty building on a Department of Corrections parcel that had been designed to hold women inmates and had just never been used. So it was unused. It was effectively pretty new because, you know, no one had ever stayed in it. And it was designed in a dormitory fashion because it was designed for women. They typically are set up a little bit differently in our state correctional institutes. So we were able to move into that space, and it has been, it did need some modifications. So at first we had about half capacity, and then we flipped it. We're just about done with that second update. When we're at full capacity, it will be able to treat, I believe it's 40 or 45 youth. And I think we're getting close to that number. I think that we've been starting to ramp up there.
Awesome. And has that facility impacted Philadelphia specifically?
Very much so, yes.
Okay. Can you talk about how?
Well, so the biggest number of youth that were waiting for placement were in Philadelphia's Juvenile Justice Center. And we were, frankly, contributing to them being over census in terms of the number of youth that they were supposed to have in care there. And so very happily, we have been able to, as I said, move youth out within 10 days or so. The statewide waiting list is between, on any given day, 9 and 12 or 15 youth. And I know PJJSC is now way below capacity. I think they're running around 80, 90 youth. So the entire system has stabilized because we've been able to expand this capacity.
Awesome. Well, I visited the Juvenile Justice Center and also the Southeast Treatment Unit. So I'm glad that everything is working out well. And thank you for all of your efforts on that. I have one more question. So what programs are available for justice-involved youth and their families to help them stay in their communities and prevent recidivism for these youth?
Yeah. So we are great believers in diversion where appropriate. And those are not programs that we necessarily run here out of DHS, but they're programs that we're very, very supportive of. And we are always happy to partner and look for opportunities for youth for whom it's appropriate to be diverted into one of those programs. And this touches on some of the things I said earlier around our child welfare system in general. We very much are trying to move this system to one that has a very preventive focus. So we know that if families are stable, if they have enough food to eat, if they have a stable place to live, the chances of that youth being involved in the juvenile justice system goes way, way down. And so from where we sit, we are trying to focus as much smart investment as possible on these preventive steps. And that's what all these investments in health are about, and all the way we're thinking about child welfare. Let's get in front of it. I don't want anybody to have to go to secure treatment, right? Like, let's get those numbers down even further because we've prevented the problem in the first place. And then that's really our North Star.
Well, thank you, Madam Secretary, for all of your work, and thank you, Chair.
Thank you.
Thank the gentleman. Representative Brown.
Madam Secretary, I would like to talk about our local community pharmacies and ensuring that these vital assets are able to remain in our communities. There was an article put out just yesterday by Spotlight PA talking about the hundreds of them that have closed across the state. And one of the biggest challenges that I hear, at least from my local pharmacies, is the predatory practices of the pharmacy benefit managers, or the PBMs. So I was pleased to welcome the signing of Act 77 of 2024, and they actually launched the signing of that at one of my local pharmacies. Governor Shapiro was there. However, I fear that the bill has not gone far enough. I continue to hear of the challenges pharmacies are facing, and I'm concerned that the number of closures since the enactment of the legislation are not going to be clearly identified just because of the way that the reporting is going to begin April 1st. So understanding that Act 77 impacts health plans under the jurisdiction of the Pennsylvania Insurance Department, what is your department doing to help community pharmacies? Is there any involvement?
Yeah, so we have no role in that bill. Medicaid just is not part of that bill at all. And the reason was that everything that the bill called for were things that were already in place in our Medicaid program. So we had already eliminated spread pricing. We already had done a number of things that that act was looking to do. We are, in the Medicaid program, our numbers show that we pay for only 11.7% of all prescriptions filled in Pennsylvania. 11.7%. It's a very tiny number. Medicare Part D pays for 42%, and commercial insurance, which is part of this bill, pays for 35% of prescriptions.
Right,
So,
but the problem, though, is that in Medicaid, the challenges with network adequacy, as patients are having to travel long distances to pick up their prescriptions because they're being forced to these big chains, the CVS's, the Walmarts. And in rural counties like mine, that's a big deal. Some of the small communities, they don't even have bus lines to get to these places.
So when it comes to network adequacy, anytime a pharmacy closes, the managed care organizations are required to ensure that there's network adequacy. And so that is something that we do monitor closely. And every time a pharmacy closes, we usually run a report just to make sure that there's pharmacies that meet the network adequacy requirements. And if there are not, then it is the obligation of the MCO through their contracted PBM to figure out how to solve the network adequacy problem.
Interesting.
I will say there is a little bit of good news that we have had a number of pharmacies close. You know, the Rite Aids were a huge chunk of it. There were 370 Rite Aids that closed, so that was enormous. And this is since 2024, January of 2024. And there were 208 that were not Rite Aids that closed. So I'm going to just kind of use 208. We've had 137 open, which is great. And this is, I have a little map. I know it doesn't, you can't read it, but you can get the idea. These are the counties in which pharmacies have opened since 2024. So they're pretty spread out. They're not everywhere, but they're in 37 counties that we've had pharmacies open.
Right.
So I do think it's really important that we talk about the fact that we are seeing pharmacies open too.
But those aren't the local. The problem is they're putting out local small businesses.
Some are local. Yeah, some are independent pharmacies.
So let me ask you this. Does the Medicaid assistance program have any willing provider clause for pharmacies? And how is your department enforcing this provision?
We do. So the way that works is we contract with managed care organizations. Managed care organizations contract with PBMs. And they are required to have any willing pharmacy as long as that pharmacy meets the contractual requirements of that particular PBM. The independent or chain pharmacy contract is with the PBM. And the PBMs do need to take every willing pharmacy as long as it meets the contractual requirements in that PBM. And so they do have some requirements.
Yeah, it's still a problem, though, because the PBMs are referring to their big pharmacies. So, but I do appreciate your comments. Thank you.
Thank you.
Thank the gentlelady. Representative Mays.
Did you say me? Oh, okay. Thank you, Chair. Hello again, Secretary. Happy Women's History Month. I have questions about one topic: childcare, childcare, childcare. So we know how important childcare is to so many families across the Commonwealth. But the cost of childcare is crushing families, including mine. Families are paying between $800 and $2,000 a month per child in our Commonwealth. So my first question to you is, how many, for the Child Care Works program, how many children and families are covered by that program? And if you could give a little background about Child Care Works.
Yeah. Well, Child Care Works is an extremely important program because, as you know, child care is extremely expensive. And Child Care Works helps offset the cost or subsidize the cost of child care for our families that are lower income families and could never afford to pay, you know, kind of the rack rates for child care. Should have numbers, and I could tell you exactly how many families we're serving. I can tell you approximately. I know that we currently have about 93,000 families that are being served in Child Care Works, and it is a really important service for them.
So, and so is there a gap between how many families need supports like Child Care Works and what we're actually able to provide? And does it come down to us budgeting more dollars for Child Care Works?
So right now today, we do not have a wait list in Child Care Works, but I will say that that is largely due to the incredible work of Deputy Secretary Brown and her team, who are constantly looking at where slots are being used and where slots are not being used, and we are able to actually move funding from one early learning resource region to another. So we have, again, been making use of every dollar appropriated to us for this purpose. And at the moment, we do not have a waiting list, but we are pretty full.
And that's amazing. So then my question goes to folks who exceed the income for their family. What resources may be available to them on a sliding scale to cover childcare?
So right now under the program, families are eligible up to 200% of the federal poverty level, and that is with federal support. And then with state dollars, thanks to all of you, we have created an off-ramp instead of a cliff for families who are between 200% and 300% of the FPL. So you can't come in between 200 and 300, but if you were already in and you're having good job success and your income is rising, then as you approach 300% FPL, you will start paying a little more, a little more, a little more, and then if then your income rises above 300%, then you will exit the program. But the hope is that it won't feel like such an abrupt departure because you've been just sort of slowly ramping up your portion of the cost that whole time.
And so that brings me to my next question. We could, as a Commonwealth and as a legislature, create an even longer off-ramp onto childcare, off of childcare, because no matter, unless you are wealthy, no matter what your income is, childcare is often the family's greatest expense, even above their mortgage. And so we could potentially extend that off-ramp to families who are making above that 200% threshold.
Yeah, you absolutely could. Again, that would need to be state dollars, just so that everyone's clear about that. But, you know, we've all seen the data that it's been suggested that from the economic development side, we're losing like $6 billion of potential work effort from people who simply can't enter the workplace because they can't afford childcare.
Absolutely.
So that would be an example of a smart investment in my view.
So I appreciate the information you shared about our districts and the impact of the Department of Human Services. On my page in House District 24, I have about 45 providers, child care providers, who participate in the Child Care Works program, but then there are also providers who are licensed but don't necessarily participate in the program. And I imagine a higher, equal or greater number of those. And so my question is, are both types of providers required to participate in the STAR program that ranks the quality of childcare?
Actually, Rep. Mays, most providers are in childcare works, but if someone's not in childcare works, do they participate in STARS? Yeah, no, they're not required to. Not required to if they're not in childcare works.
But they are required to if they are a part of the childcare works program.
And it is the majority of our childcare providers do participate in childcare works.
So thank you very much, Secretary. I have so many more questions about childcare, as it is one of the most, if not the most important affordability issue for families all across the Commonwealth. Thank you so much, and thank you, Chairman.
Thank you, Gentlelady Representative Flood.
Thank you. Madam Secretary, based on an earlier line of questioning, I just want to dig a little deeper on the emergency waiting list. In February of 2024, your department announced a multi-year strategy to end the emergency waiting list for individuals with intellectual disabilities and an initiative to manage waiver capacity by the amount budgeted instead of slots. And while you have shared that there have been a significant reduction in the emergency wait list, which I think you previously said it was reduced by 31%, which is great, how are you ensuring that the individuals are receiving these services that they need through this new budgeting process? Do you track and manage the funding capacity, and who receives what services, or is that done at the county level?
So each of these individuals has an assigned supports coordinator that works with them, needs to lay eyes on them, see them in person every 2 months in the ODP programs, and assesses their needs. And of course, the needs are assessed by, physicians and other care providers that are taking care of them. But those needs are assessed. And then there's these regular visits to make sure that their plan is being met in terms of meeting their needs.
But, do you track the funding capacity? Is it done through the county level? Is there oversight to that?
Kristen, do you want to get into some of those details? Yeah. I'll bring up Deputy Secretary Ahrens to give you the specifics on that.
Always on. Yes, we track that. So we work really closely with our county partners, and before we implemented the new multi-year program growth strategy, one of the things that we did was we created a dashboard that every county has access to, and so they can see what expenditures in every category, they can see their authorizations against their expenditures, so they are managing to that budget on a county level, and then we are reviewing that at a state level to make sure that we are staying within our appropriation.
Thank you. And then at what point is an individual removed from the emergency wait list? It's my understanding that individuals removed from the list receive some level of service, but not the entirety of what they're entitled to. What's the average time from eligibility determination to service initiation? And can you describe how this process works, please?
Sure. The emergency waiting list, the waiting list in general is for people waiting for enrollment in a home and community-based waiver. And so once a person is enrolled in that waiver, then they are removed from the waiting list. Because once they are enrolled in the waiver, we are obligated to meet all of their assessed needs through the services or through unpaid supports. And we have a variety of situations. So we have individuals that come in and the services are available, there are enough staff to meet all of their needs, and there are no unmet needs. We do have people that are enrolled that struggle with finding a provider who has the staff to staff them up fully. And we do have people that are waiting for some services again because of, typically it's a workforce issue.
And what is the average time from eligibility determination to service initiation? What's that average time frame?
The requirement is actually 45 days.
45 days, okay. And while your department has moved towards managing waiver capacity by the amount budgeted versus slots, The fiscal year 26-27 budget proposes an additional $20.9 million for the placement of 400 individuals into the consolidation waiver and $9.2 million for the placement of 850 individuals into the community living waiver. How were these figures determined? Are these placement numbers estimated based on the budget to the person initiative or the traditional budgeting by slot?
So let me pull that back a little bit. So you recall the governor in 2024 made a commitment to ending the adult emergency waiting list, and it was going to be a multi-year commitment.
Right.
And there's been multiple aspects of that, focus on workforce development, all sorts of pieces, but one of the pieces was to simply increase capacity. And so these numbers that are in the budget are the way that we have always put this information into the budget. So we are asking for 400 consolidated waiver slots, which is the big one, the most comprehensive one, and 850 community living. And that's how they go into the budget. But if a county, so let's say Montgomery County gets 2 consolidated waivers and 5 community living waivers, they'll be getting those slots. And if they have individuals to go into those waivers, they'll be able to put them in. But if an individual is not using all the services allowable in that particular slot on day one, and there's services that they might not need for a few years, they won't lose access to those services when they need them, but we'll make that funding available to someone else who could use those services right now today.
So what you're saying is it's a mixture of both. Slots
Yeah,
and, okay.
exactly.
All right, just I wanted to clarify that. So, okay, thank you so much. My time is out.
Thank the gentlelady, Representative Kincaid.
Thank you, Mr. Chairman. I want to talk about Sunbucks. Is DHS working to improve the timeliness of the Sunbucks program, given that summer is the hungriest time of year for food insecure kids, and delaying the receipt of those funds into the fall is not achieving the goal of feeding kids over the summer?
The short answer is yes. So as you know, we were very excited to launch Sunbucks in 2024. That was year one of the program. We had, I think, only 6 months notice from USDA, and we were able to get this entire program up and delivered very successfully. So last year was year 2, and we did better. We were able to get the benefits out a little bit earlier. There's a couple factors. There was a bit of a data glitch last year that we are hoping has been fully resolved. But the other issue is one that we are not able to solve entirely on our own. And I want to be clear that PDE has been a wonderful partner in this work, and they have been absolutely essential in helping us reach out to all of the local educational areas across the Commonwealth, which, as you know, there are many. And there is no central repository in this state that requires that any children that are in the reduced or free lunch program be entered into that. Other states have that, and so when they're implementing summer EBT, they can literally just pull those kids and say these kids are eligible. We have to get information from each educational area, and so it is a bit time consuming. We're working with PDE to make that a smoother, easier process for all of our local schools, and we got better in 2025, and we're hoping it's going to be even better in 2026.
Thank you. I actually had offered to introduce legislation to address that issue, but your department and PDE both told me that that was not necessary, that there wasn't an issue. So I would love to actually have a more clear conversation about that,
Sure.
if there is in fact an issue.
Yeah, I think if we could get through 26 and see how we do, and then if it still seems that there might be, we haven't solved everything perhaps we thought we solved, then perhaps we can re-up that conversation.
Thank you.
Yeah, thank you.
I want to go back to talking about our rape crisis centers. I think it's important to acknowledge on the record that the money that comes from DHS does not actually fund attorneys for these centers. And so, you know, as our good chairman is often quoted, budgets are moral documents. And so if we are really going to send a message to our sexual assault survivors, having this be something that is consistently a political football that is flat funded, and then the legislature is responsible for putting that money in, I think that it sends the wrong message to our survivors. So I would very much like to work with you guys to actually send the right message to our survivors. I want to turn to a thing that we talk about often, teeth. And in this Commonwealth, teeth remain luxury bones. And this budget proposal, once again, fails to address that. And we've talked today a lot about how we could save in Medicaid if we actually, address prevention and actually having access to dental care for folks would prevent a lot of chronic and significant serious health illnesses. Why are we not putting that money in the budget?
Well, as you know, this is something that has been frustrating, I think, for a number of years since the full dental benefit was removed from Medicaid back in 2012. So the 2026 Health Choices Agreement does include $24 million of state funding for state-directed payment to dentists as part of the capitation program. And we have heard from dentists that has been helpful to them. We have also continued to work to streamline our dental benefit exception. So for people who have a serious problem and need a root canal or some other type of intervention, we know that process has been cumbersome, and we've really tried very hard to streamline it so those folks get lifted up and approved quickly where possible. And then we are continuing to work on the workforce side of this in a couple of different ways. So one is we have a 2-year pilot project with the American Dental Association, the Department of Health, the Oral Health Coalition, and 5 other states to create a blueprint to improve provider participation in Medicaid. And there's a couple different goals of that. One is just to increase the number of participating dentists, but maybe even more importantly, increase the number that actually see a meaningful number of Medicaid patients. And so the goal is to increase the number who see at least 100 or more Medicaid patients in a year by 3%. And we're working with strategies and ideas to make that happen. And then just in general, because we've had kind of a generation of folks who haven't had a dental benefit, there's a piece of education here to help people understand that they should utilize these benefits, right? Like that's just a whole, so we're doing all of that. And then we are also one of 11 states that were competitively selected for the Medicaid Oral Health Workforce Implementation Learning Series, which is a national initiative led by the Center for Healthcare Strategies. Dr. Shamlu, our Chief Dental Officer, who's terrific, has been leading all of this work. And we are making slow but steady progress. And our hope is that coming out of this, we'll be able to come back to you with ideas around funding that is as efficient as possible and would actually help support this workforce and improve access to folks in Medicaid.
Thank you. And thank you for your indulgence, Chairman.
Thank the gentlelady. Representative Krupa.
Thank you, Mr. Chairman. Madam Secretary, I'd like to initially go back and get clarification on something. My understanding is that the fiscal note in June 2025, and this is with respect to the minimum wage issue, that it would have, that fiscal note indicated that it would be an $88 million increase to the CHC program if at that time the minimum wage had been increased to $15. Is that correct?
That is, I believe, what was in the budget.
It was in the House Appropriations fiscal note. That's not a calculation that DHS performed.
Okay, but based on documentation that was provided to the House Appropriations, that was the estimate for the increase?
If you say so.
Okay.
I don't have it in front of me.
Okay, but just for clarification, with regard to your answers to Representative Barton earlier today, you've indicated that if it's raised, the minimum wage is raised to $15 now, or by January 1st, 2027, that there would be no increase because the market's already achieved that gain, correct?
Yeah, so the way that we set the capitation in our Community Health Choices Managed Care plans has used as an assumption that is what the wage would be by January of 2027. And so they have incorporated that into the capitated rate calculation.
Okay, so let me get clarification on that, because with respect to your testimony earlier, is it the market that's increasing it, or is it that you're assuming that the minimum wage will legislatively be increased to $15 per hour?
The market.
Okay, good. Isn't it? I just love the way that the free market works. Thank you. I want to pivot to the Federal Response Fund. The governor is proposing the establishment of a new fund, the Federal Response Fund, to respond to and mitigate any action or inaction by the federal government that results in a reduction in funding to critical programs that impact the health, safety, and welfare of Pennsylvanians. He goes on to specifically cite programs supporting disaster recovery, among others, as they were determined or are determined by the Secretary of the Budget. Have you had any discussions with the governor related to this proposed fund? And if so, can you share what type of potential responses that fund will be used for?
Well, I think ultimately that will be up to the budget secretary, so you can certainly ask him about that. But I have had one specific conversation around this, and that is what we saw during the federal impasse, where for the first time ever, the federal government chose not to use the SNAP Emergency Fund to continue to pay for SNAP. And of course, we saw lines around the block at many of our food pantries because literally overnight we were not able to deliver those benefits. And so I think that was one of the very tangible and very visible things that happened in this last year. The governor moved as quickly as he could. I know he was able to get $5 million of state funds to help our food pantries and, sought other contributions from charitable entities and things like that. But I don't think any of us ever want to go through that again. And so I think that was part of what was behind the creation of this fund. But there's been other agencies, too, that have had.
So my understanding is that the governor intends to finance this new fund through the Budget Stabilization Reserve Fund, commonly known as the Rainy Day Fund, and that he's proposing taking $100 million from the Rainy Day Fund for this purpose. Given that there's already a process in place to use the Rainy Day Fund to appropriately respond to issues of health, safety, and welfare of Pennsylvanians, why is this new fund needed?
I don't know the specifics of that. That would probably be a question better suited for the budget secretary. But I do know that when the SNAP situation happened, it was very limited in terms of what the governor was able to access. So I think my understanding of this is it would be a short-term, nothing ongoing, a short-term, it would create the ability for a short-term response to a sudden and unexpected cut from the federal government, like what we saw with SNAP.
So if this fund's ultimately established, would an act of the General Assembly be needed in order to access that fund to, in turn, respond to a potential situation?
I think that's one for the budget secretary.
Thank you very much.
Thank the gentlelady, Representative Salisbury.
Thank you, Chairman. I may have been a bit of a broken record lately, but I have been very concerned about the issue of disinformation related to autism that has been coming out of the federal government over the last maybe year or so. I wonder what role you feel that Human Services or you personally may have in dispelling some of that disinformation, because I do believe that at the state level we have an obligation to try to promote science rather than pseudoscience.
Yeah, very, very timely question. So we have been partnering with the Department of Health and other initiatives that the governor has also promoted to make sure that Pennsylvanians have accurate science-based sites to go to get information. DOH has stood up a whole webpage with information about vaccines. The governor has made it clear that we are following the guidance of ACOG, the American College of Obstetricians and Gynecologists, American Family Medicine Society, and the American Academy of Pediatrics in terms of the vaccine schedules that are recommended by those groups that are continuing to use science-based information for those recommendations. And I think at every opportunity, We are all being very clear that this is a state that's going to operate based on science and pointing to people to those trusted resources.
I am very concerned about the, shall we say, alternative treatments that many parents try to undertake for autistic children, some of which can be very dangerous. We have people giving their children antiparasitics and a variety of other medications. And leucovorin, of course, was mentioned by the Trump administration as a potential treatment for autism. I wonder, you know, we've had some people talk today about whether the state will be paying for weight loss drugs. Will the state be paying for pseudoscience treatments for autism in any capacity?
Well, we certainly would not be paying for leucovorin or any of those other types of treatments for autism now.
So no ivermectin or things of that nature to clear out the parasites in your child that might be causing autism, some people believe?
Not for the diagnosis of autism.
Well, who knows if I myself have autism-causing parasites, but I haven't undertaken that course of treatment myself. But I wonder, just to shift gears a little bit, in terms of disability services in the state, there was a recent court decision related to provision of disability services by family members. And I wonder if you could talk a little bit about how that will impact family caregiving going forward, particularly as it relates to children on the spectrum.
Yeah, I appreciate that question. We just got that decision a week ago. Maybe it's been 10 days ago now. We have, our attorneys are still understanding what is in that decision, so I'm not yet prepared to be able to tell you what the impact will be. We're certainly, once we have done all that, we can certainly follow up with you once we've had a chance to really unpack that decision.
And also, I understand the state certainly doesn't have the budget anywhere near the federal government's for investing in research, but since we've seen a shifting away of research funding at the federal level from traditional autism research toward a vaccine-oriented or Tylenol-oriented origin theory, does the state invest in any way in assessing potential other causes of autism or investing in any type of research?
So I think the Department of Health does have some funding directed at those types of undertakings. And then the Governor's Office of Transformation has actually been working with a number of academic health centers and others about just bolstering the clinical trial infrastructure and conduct of trials that is happening across the Commonwealth. I think hoping to really capitalize on our many just outstanding academic institutions. We have many very strong pharmaceutical companies in the Commonwealth, and looking at ways to bring that all together to make it easier to conduct clinical trials here in the Commonwealth. And so there may be some opportunities down the road for some of that type of work that are greater than what exists today.
And I will finish by saying that I always advocate to make sure that people don't forget that autism doesn't go away when you turn 18, that services are still required for autistic adults as well. So I hope that your department bears that in mind. Thank you so much.
Yeah, thank you.
Thank the gentlelady. Representative Reichert.
Thank you, Mr. Chairman. Secretary, thank you again. It's good to see you again this afternoon. Just following up a little bit on my questions from this morning about the community engagement requirements for SNAP benefits. In the 59,000 folks that have lost those benefits since H.R. 1 has taken effect, you mentioned that the vast majority of those folks are eligible, but it's an administrative thing. There's issues with paperwork and that sort of stuff. What's the department doing to ease that burden or better engage with these individuals who are struggling to get the paperwork in, but meet all their other requirements?
So let me just clarify one thing. My statement was about other states who have previously tried to enact work requirements, often found that many of the people who lost their benefits were actually meeting the requirements. I don't actually have information right now today about those 59,000, but those individuals are certainly able to join any of our employment and training programs at any time. That information is readily available to them, and as I mentioned this morning, we are working to identify a much larger universe of employment and training programs across the Commonwealth so that there's way more opportunities than currently exist for those programs. And then they are getting information from county assistance offices. You know, they're told if they meet these requirements, they can come back.
Sure, but how are you collecting that information? Like when if I am volunteering in the community, for example, for 20 hours a week, how am I getting that
How does
information?
that happen?
Yes.
Yeah. So we ask the volunteer entity to fill out a form, and then that form is uploaded by the person who's doing that volunteer work up through our portal, and then that gets attached to their record.
So, Secretary, I actually have a copy of that form right here. It says instructions, please mail or fax within 10 days to the office. Nothing about uploading to anything along those lines. Secretary, I have a fax machine in the office. I don't know how to use it. So.
Yeah, we're close. We will be close to being able to upload those.
Oh, okay. So we're not there yet. So it's been 7 months since the legislation was passed. Do we have a timeline on when people might be able to upload this, or maybe an app or something like that, or maybe scan an email or something like that?
Deputy Secretary Pham will do her best to answer that question. We've had a lot of issues we've had to deal with.
Good afternoon. I really appreciate this question, because I think Secretary Kush alluded earlier today that experiences in other states who have attempted to implement work requirements or have implemented some degree of community engagement requirements and public assistance programs pretty clearly indicate that a fair portion of people who lose their eligibility are doing so because they have difficulty navigating through the process.
Right, so we should make it easy as possible, right?
We are doubling down on trying to make this as easy as possible. Again, we don't want to see people lose eligibility because of the bureaucracy. So the example that you've shared here, yes, that is but one of many forms and options that SNAP recipients, and in this case, community-based organizations, 501c3 organizations, who are hosting volunteers as a way to fulfill their work requirement can complete it. Yes, you are right. It currently indicates mail fax. We are trying to lift many, many ships and support multiple reporting mechanisms. We are working now to create, I'm going to call it the one form to rule them all, a streamlined form to capture the myriad ways in which a SNAP recipient can meet their work requirements. So right now, again, that form that you have is just for community service. We have a separate form that we would use for someone who's enrolled in a job training program,
Sure.
for instance.
Is it a fax and send, fax and mail too?
And a separate, no, and a separate set of documentation and verification processes, for instance, for someone who's meeting the work requirement through work. Ideally, our target is to create a singular form that can be shared, reported to the department through multiple ways beyond just mail and fax.
Okay,
we are
good.
working vigorously to get this done because, as the Secretary alluded before, all of the infrastructure that we're building now for SNAP can only pave the way for how we implement more effectively for Medicaid.
Well, but like to determine eligibility now for work, I mean, isn't there an interface that DHS has with employers? Wouldn't there be a logical next step to maybe to use that to help verify and continue? I mean, there are a lot of things in place. It's just a matter, I guess, of tying them all together. Is that
like for the work piece? I talked about it earlier. This consent-based verification and some of these other tools are already online, and then it's just taking that next step. I know that it's kind of incomprehensible, but our systems are still being modernized, and they're almost there, but there are aspects of them that are still very last century, and we are working quickly to update them, and some of these forms and other things are caught up in that process. We're getting there.
Thank you. As I say, I think the faxes are from the 80s. I think hopefully we can advance to the 90s and maybe use email at some point.
Well, listen, we're fixing it for the doctors who are also still faxing in prior auth, so we're getting there.
Good. Thank you, Secretary.
Yeah. Thanks, gentlemen. Representative Fleming.
Yeah, that one's not on. Maybe that one? How about right there? Oh.
All right, start the clock. Thank you.
Ooh.
Thank you so much. Thank you for your indulgence. It's been a long day, but I want to first touch on something that Representative Mays brought up about the high cost of childcare. While I no longer have children in childcare, I know there are a lot of working families who are struggling. I just did want to point out that I will be working on an initiative, and I hope to have the department's support to align Child Care Works with pre-K counts and make it more generous, in fact, to see if we can get up those limits to 400% of the federal poverty income guideline. If we were to do that, it would only be about the federal poverty income guideline would only be about 15% more to meet that standard than what I make as a rank and file legislator. So I think we need to be a lot more generous with those programs. So again, I'm looking forward to working with you on that initiative. And what would that do if we were able to do something like that and sort of expand the pie? And I know you said it will take state dollars, but you also said it'll be a smart investment. What will that do for our families in terms of access?
You know, I think it'll help families a lot. Look, we know that families are facing so many challenges right now. Housing across the Commonwealth is extremely expensive, which is why the governor's proposed the Housing Action Plan, because we simply do not have enough housing. We have a very high percentage of people who are paying more than 30% of their income, either toward rent or toward a mortgage, and that is just not sustainable. We know that food prices have gone up considerably. Some of that's due to tariffs and other issues that are facing us right now. So I think anything that we can do to just make it a little bit easier, a little more affordable for families would be a huge win. And we all know, I'm sure you've had friends who they got to a certain point and the math just didn't math.
Right.
Like people lose this little bit of support, and even though it seems relatively modest, it's enough for them to pay all their bills. And then they start to make a little bit more money and they lose that piece. And the increase in wages don't make up for what they're losing. And this has always been, the difficulty. So the more we could limit that, the better.
And quite honestly, I think, a lot of this lies at the feet of our federal government, to be honest, which has not recognized the reality of where, incomes are today, how much people are struggling today, because I think the guideline itself could use some work and some massaging as well. So thank you for that. I wanted to pivot to Centers for Independent Living. I have a wonderful organization in my district, Thrive Center for Independent Living, and the mission is kind of shared between like the Office of Vocational Rehabilitation and DHS in part to try to help individuals with disabilities live on their own, live independently. So I did want to ask, can you tell us how DHS's budget provides funds for an increase in home care wages and provider rates for those, we're talking about OLTL, community health choices, and OBRA waivers, for those folks who are trying to provide for folks with its disabilities to live independently?
Sure. So right now, the only increase that is available, and this is of course from the 25-26 budget, is in the participant-directed program.
Okay.
And those are workers that are hired directly by the participant. They actually work for the participant. And that is where the $24 million that was appropriated last year is going, to that particular set of the workforce. And that decision was made because those workers have not been on par with agency workers in most circumstances. They don't have any benefits. They've never had any kind of paid time off or anything like that. And so the goal with them being able to get an increase is they still don't work, for someone that gives them benefits, but hopefully will give them additional income with which they could hopefully then purchase some benefits or afford to take a day off. It's that sort of approach. In terms of direct care workers that are working for an agency, other than the increase in rates that is in CHC that we've been talking about, that we assume a trend, CHC MCOs are getting an increase.
Right.
And I encourage agencies to negotiate with their MCOs. MCOs are not tied to the fee-for-service rates, that that is what there is right now. It's just
okay.
simply the increase that is in there for CHC rates.
So we have some more work to do, but I will say those are indispensable parts of our community. So thank you so much, Secretary. Thank you, Mr. Chairman.
Thank the gentleman, Representative DeVanzo.
Thank you, Chairman Harris. Madam Secretary, my question is on the OBRA waivers and some of the EODP waivers. I continue to hear from some of the families in my district, very few providers willing to accept the individuals on the OBRA waiver. And when they do, some providers take nearly most of the money off the individuals, their Social Security. It seems like once they determine how much money the patient has, that kind of determines their room and board with it. So my question is, are there any safeguards, or is there any safeguards maybe that we could put in place to help protect some of our patients that maybe seem like they are being extorted a little bit?
Did you mention something about paying room and board? Because we do not pay room and board in our program.
Okay, just in general.
I guess I'm not totally understanding what the question. So it's about the OBRA waiver.
Yeah. So it would have to do with the waivers at some of them, and what it is the price for the patient is on Social Security. The OBRA waivers are taking most of her money, and they're leaving her with very little money for the month.
Oh, are you talking about the personal allowance, maybe,
Yes.
for individuals that I understand? Okay, if that's what they're talking about. So it is correct that in some of our programs, the provider is allowed to use a portion of the Social Security income to help fund and cover their costs for being in that program. That actually reduces the state spend in those programs. And so we do have something called a personal allowance that the General Assembly actually increased that amount 2 years ago. I believe it was in the 24-25 budget. Is that right? And what's it up to now? $85? Yeah, I think it's up to $85. That is something that the General Assembly could choose to increase again, but then there would have to be a backfill. So let's say you increased it to $100 for those individuals. We would need to then backfill with state dollars that delta.
All right, perfect. And then whenever they wanted to move from the OBRA waiver and go to an ODP waiver. There seemed to be some hiccups. I don't have them exactly. Maybe you could touch on it a little bit. But would there be a way to get them on a level playing field? It would probably help us get more providers in, and it would, help my constituent just live a little bit more comfortably as well.
Yeah, so I'll try to keep that answer brief. It's sort of a long story, but we have individuals who have intellectual disabilities or autism who would have, had we had plenty of waivers in our ODP program, and again, this is the adult emergency waiting list that the governor's pledged to end, they would have gone into one of those waivers, but those waivers have a waiting list. Our Community Health Choices program is an entitlement program. And so if they met the eligibility requirements for that program, that we do have people with IDA who are in one of our Community Health Choices programs. Now, for some people, that's okay. If mostly what they need are nursing services, the CHC program might be a really good fit for them. But for other people who are looking for services to help individuals with disabilities, autism, intellectual disabilities, continue to grow and thrive, the CHC program may not be the best fit for them because they don't have workers, staff, direct service providers who are trained for the IDA population. And so if a person's entire needs are not being met in the CHC program, they remain on that adult waiting list in the ODP program, but they're kind of at the back of the list because at least some of their needs are being met. The hope is as we work through this waiting list and we get all the people that have no services right now, get those services met, then we will start to work on this other group who have some of their services met, maybe through CHC, but want to come over to ODP. But our priority is the people that currently have no services.
All right. I appreciate your answer. Yeah, I know it is a complicated issue to dive into, all the acronyms and everything. Just complicate it a little bit more. But
feel free to reach out. If there's some specific case you'd like us to take a look at or something, we're happy to do that.
All right, no problem. Thank you. I appreciate that. Thank you, Chairman.
Thank the gentleman, Representative Young.
Good afternoon.
Good afternoon.
When people lose coverage, they will often delay getting care that they need, and their condition oftentimes worsen. This leads to them seeking emergency care, which the hospitals, as we know, must provide. How are you working with both the Department of Health and the provider community to plan for the increase in uninsured individuals?
Well, as we start to, particularly once these Medicaid requirements kick in January, that is where we're going to really start to see people lose access to their Medicaid health care. As we've talked about today, folks who had Penny, 104,000 of them to date, have already said, I can't afford this any longer. Right. So we are always mindful to try to give people other resources like federally qualified health centers or other clinics in their community that offer care that is either free or kind of a payment on a sliding scale, depending upon what that person's income is and what they're able to pay. Sometimes they can provide a pretty full set of services for some individuals. But other than that, we do not have a system in this country for individuals without insurance. The only other backfill is someone who has a truly emergency situation and then shows up at an emergency room or a provider. Hospitals are required to care for that person, but there's no way for that person to pay the bill. And so that becomes a person with a medical debt, and then the hospitals have no recourse other than to increase their prices for everyone who does have insurance, and that then leads to increasing insurance costs for everybody else. And so what I often like to remind people is, people often say to me, what does it matter what happens in Medicaid? You know, I'm not on Medicaid, but that's not the point. What happens in Medicaid actually impacts literally every single one of us, because as uninsured rates go up, the price of everybody's health care go up, no matter where you get your health insurance from.
All right, so you brought up a great point when you're saying that we need to provide the resources and the information to the providers to ensure that they're communicating effectively with the patients and making sure everybody is on the same page as it relates to being educated about it. Now, we also know that there are so many different ways in which people receive information, and so with these changes happening, oftentimes people don't even know they don't have coverage until they actually go to seek care. So the way in which we communicate in these spaces have to be very specific and streamlined. How do you propose, or what recommendations do you propose that we as legislators can help with the provider community along with the systems to ensure that the people who are in need of service and preventive care, how do we best communicate with them collectively?
Well, this is where we're really hoping you can help us. You know, you all know your districts best, and you have, however you communicate, district newsletters, social media, town halls, whatever you do. You know, we hope that you will be able to share this information through your channels. We have, in particular when it relates to all these new community engagement requirements, this webpage I mentioned earlier, it's at dhs.pa.gov/work, with all sorts of resources on it that you can download for free. There's frequently asked questions, all sorts of information, and anything that you all can do to help get that word out across your districts, we would be deeply grateful for, because you're 100% right. People have so many different ways that they receive information today, it is almost impossible to keep up with them all. And so it's an all hands on deck moment for us right now. We need help from everybody.
Right. And finally, my last part is, finally, you spoke earlier about the specific challenges that private equity brings in the healthcare system. You talked about the legislation that recently passed the House that will give the Attorney General more authority and oversight. What are some of the unique challenges that occur when the private equity firm purchases and provides healthcare services?
Yeah. Well, we've seen this play out both in hospital systems and in many of our nursing facilities. You know, this is the problem in both places. And typically what we see is a private equity firm comes in, they purchase a hospital or they purchase a nursing facility or a set of nursing homes. And the first thing that typically happens is there is a lease buyback of the property.
So the property is sold to a real estate investment trust. That's usually the primary way that the private equity folks get their money out. So they're like out pretty quickly in terms of getting their investment back. And they create these leaseback situations, which then this entity, nursing home or hospital that's never had to pay rent before, is suddenly having to pay to sit on their own land. And right there, that can add millions of dollars of operating costs to a hospital, and just starts a clock where we see over the next 3 to 5 years the inability to maintain a positive operating margin. They often consolidate staff. What we've seen in our nursing facilities in particular is entities that were higher up on the, Medicare has a star rating for nursing homes. And let's say when they were bought, they were 3-star or 4-star. We tend to see over the course of the next year or two that those nursing homes move down to a star 2 or star 1 rating. Often that's because the quality of services deteriorates. They do the absolute bare minimum of staffing ratios, just basically things that they can do to save money. And that's what we see. And a couple years, 3 to 5 years in, most of these places are in trouble. In the nursing home side, some of these entities put up a great deal of resistance to paying their nursing facility assessment, which creates problems for us. So I really hope that the Senate sees fit to pass this legislation to make it just a little harder for people to come into Pennsylvania, and it will increase the transparency of who are these people. It's layers of people, and it's very hard to unpack.
Right.
So I'm very grateful that the House passed this legislation.
Thank you so much.
Thank the gentlelady, Representative Nelson.
Thank you, Mr. Chair. I appreciate the opportunity for a second round of questions, and I would like to just very quickly start in the area of our families that are dealing with members that have intellectual disabilities. It's great to see the waiting list going down, but I'm hearing from some of those constituents in our area that the families that may have been approved for a waiver are really struggling to receive the services because there isn't anybody available. So I was wondering, does ODP track utilization, or is there a way that we can see, because they're getting approved, but then they just can't get the help they need?
Yep, absolutely. The workforce issues in this area have been top of mind now, certainly at least in the Shapiro administration. And during COVID, there were a number of ways that ARPA funds were used to help bolster this workforce. And then again, with your support, there was a very significant investment made 2 years ago, and I can't remember what the number was. It was on the order of $400 million?
I think $280 million in state funds.
Yeah, so total 400-some million to increase wages for direct service providers, the DSPs that provide these services. And we have seen really good outcomes from that. We have seen that wages are indeed higher for those workers. We think they're about $2 to $2.50 higher per hour. I'm getting tired. For those workers. And we've also seen that the vacancy rate for DSPs is down to 14%, which is the lowest it's been in a number of years.
That's good to see.
So we're making progress. Yeah, it's not, I'm not checking the box. I'm not checking the box, but we're making good progress.
When you had mentioned earlier that some counties were taking a new budget approach, I was texting with Westmoreland County Human Services. They're very interested in being approved or wanting to implement that new approach moving forward. There, a lot of innovation there. So I'd like to shift back to the BAF. There's been a lot of questions. Personally, I'm fortunate to serve on the Aging Committee, and something that we talk about a lot is the silver tsunami. We're about 3.4 million Pennsylvanians are 60 or older. So just in 4 years, we're going to drop down to 1 in 3 Pennsylvanians being over 60. So that 65 plus population is really coming, So to me, we have to begin to address this nursing home issue. You know, we've had a lot of nursing homes closed. I think there's been 30, over half of them have been in the last 2 years. That's about 2,000 beds. How can we begin to take some steps to better support this area?
Yeah. Well, again, and this is nothing to say about our nursing facilities at all, but people are choosing to stay in the community if they are able. And despite the fact that we've seen a number of nursing facilities close, most of our nursing facilities right now are at 65-70% capacity.
It's interesting because Leading Age had sent numbers much higher than that, you know, and they're an advocacy agency in that area. And even DOH numbers show that, yes, they dipped during COVID, but our year-over-year utilization has been increasing. So for those older Pennsylvanians that need skilled nursing, like, we have to have a place for them to go. You know, I mean, even, and it's great, people can go and stay in the community, but if I'm correct, both nursing homes and our community services are flat funded in this budget, like neither one. Last year, a sliver of home health got a bump, but like, I really think we have to start chipping away at this issue between nursing homes and home health. I mean, what are we going to do?
Yeah, I mean, I think it's an area where we have to be very thoughtful. It is more expensive for an individual who meets criteria for nursing home care to be cared for in a nursing home versus being cared for in the community. And remember, I do want to make really clear, because obviously this is really in the weeds, but when I talk about home and community-based services, I'm talking about people who meet the clinical eligibility requirements to go into a nursing home. So these are not, you know, these are people with a lot of needs. And it is still less expensive to care for them in the community. And so again, as we have an aging population, and believe me, we are very focused on that as well, we're going to have to figure out where's that balance and what amount of funding is available to be appropriated to these purposes.
Great. Thank you, Mr. Chair.
Thank you.
Thank the gentleman. Representative Curry.
Thank you, Chairman. Hello again. I wanted to bring some light and attention to women's health equity, and I just thank you for all the support that you have continued to give around the PA Black Maternal Health Caucus and the Momnibus legislation. I know that the maternal strategic plan is about to be announced, and looking forward to that event. I would like to know if you could give us a few highlights from that particular strategic plan. And I also want to ask you about the lactation program that you and I were privileged to go and witness. I think you were still on your crutches then, and we were running through that, that program. Secretary was here earlier this week around the corrections facility, and one of the things that I asked her was about that lactation program, which, you know, funding was put into and really planned out around helping women who are inside the walls to be able to have that particular program. I want to see what your thoughts are around that, because Secretary Harry did say that that program isn't flourishing the way they'd like, so I just want to see what your thoughts on it. And lastly, I want to ask about the birthing centers here in Pennsylvania, knowing that the Life Cycle Wellness and Birthing Center stopped birthing babies in my area on February 15th, where they are used to birthing about 600 babies, and gynecological care ends this month. I know that was a lot, but if you need me to repeat anything, thank you.
Yeah, life cycle closing was really a heartbreak, such a loss across the Southeast. They've cared for so many patients, so we were all really sorry to hear that. I'll start with that one. We are in the Rural Health Transformation Fund, and I actually neglected to mention this earlier. We are able to put some funding through the RHTP toward an entity who would like to start a birth center. And what we're doing, we can't build one, we can't use money for things like that, but we can help pay for certain things associated with a birth center. And one of the things that we're hoping to do is to put together just kind of almost like a work plan for if you were a hospital that wanted to start a birthing center, what would be the steps to do that? Or if you were some other group of providers that wanted to put together a birth center, what would it look like to do that? We want to make it as easy as possible for these rural communities to try to grow access to those services through a birth center if their local hospital doesn't have it in their business plan to restart OB or provide OB. In terms of the maternal health action plan, we are very excited to finally announce it. It's been a long time coming. And another one of these areas where, as you know, we went all over the state listening to folks in multiple different communities to hear what their needs were. And our goal is to make sure that anybody can access high-quality prenatal birth and postpartum care that's person-centered, that's comprehensive, equitable, and affordable, and that results in improved health outcomes for both the mom and the baby. So we're really excited about this plan. There have been aspects of it that we have been working already to implement through the Jewish Federation in Pittsburgh, in the Pittsburgh area. They have actually had an RFP out. I think it's just closed or about to close to fund some of the priorities in year one. One of the priorities was to get this doula apprenticeship approved, which we've now done. And again, in the RHTP, we're hoping to have some money specifically to fund doulas that will work in rural communities. So we're excited about that. And we're just going to continue to work together to provide the services that we identify that would be the most meaningful and helpful in this space. You know, we're very much guided by Department of Health's Maternal Mortality Review Committee work that points us in the direction of areas where we need to bolster services to help reduce maternal morbidity and mortality. And I hope, you know, working across all of our agencies and with all of you, we'll make some good progress here.
That's awesome. Do you have any comments before the time runs out about the lactation program?
Oh, yeah. You know what? Honestly, I have not gotten an update on that recently, but I am happy to do that and see what information I can get and follow back up with you.
Thank you so much,
thank you.
Secretary. Appreciate it. Thank you, Chair.
Thanks, Gentilini. Representative Kale.
Thank you, Mr. Chairman. Thank you, Secretary. I promise this line of questioning will be far more boring than our last exchange. A source of frustration for me and for many of my colleagues, not just with your department's report, but also departments across the board, is how the projections are being handled year after year. Our job as legislators is to ensure a fiscally sound budget. That's probably one of our main functions. And understanding where costs are going to be, not just for this year, but in years ahead, is absolutely critical. Because unlike DC, and I would say thankfully, we don't have the ability just to print money. We actually have to have a balanced budget to an extent. There's obviously certain caveats to that. And it's very important for us to have a firm grasp on not just what the costs are going to be for a department this year, but also next year and the years going forward. I think that's why that is constitutionally required and statutorily required to have these projections from the departments. Looking at these projections that we saw and looking at years past, I believe last year the projection for the budget we are discussing today was something like 1.5%. And here we are talking about a 6% increase. And I understand there's reasons for that, and we can have dialogue on that. But in order for us to be more prepared going forward into years going forward, and not just end up with a situation where we're at a fiscal cliff where we need to start talking about cutting from this department or that department or trying to find different ways to raise revenue. It's important for us to have that planning mechanism. So I would just ask you the 0.8% projection increase for next year. My question is, even with the statutory, and just with, rather, the statutorily mandated functions of your department, wouldn't the cost be more than that next year with the growth of what's happening around us?
I think it's really hard to predict with all of the uncertainty at the federal level and with community engagement requirements taking place in the Medicaid space beginning in January of 27. I think it'd be very unrealistic to predict that spending would continue at, say, 6% in your example, which is why we have a lower 1% placeholder.
And, okay, 6%, but when was the increase in budget at 1%? Has it ever been there? I don't think the Shapiro administration has actually put forth a budget where it was at 1%.
I think that is true from the Shapiro administration. I don't think that we've seen that. What's difficult is at the time that we project those out years, we do that, we hold certain lines flat. That's a traditional budget practice. There's also our inability to predict what happens in the budget negotiations. So there are things that occur in negotiations that are not part of planning. So those things take a role, and there are also other policy decisions that happen through other legislation that we can't predict either.
And I would just ask, 0.8% is not where this is going to end up next year. We're going to be here a year from now, and I could say with confidence, and I would guess you could say with confidence, that we won't be discussing 0.8, whatever it is. I don't know if it's 0.86, 0.83, 0.8% increase. In order for us to have a firm foundation to put the Commonwealth on sound fiscal footing, if we could get some more realistic projections, I mean, that would be something that would be very helpful for us as legislators, because we're running into a situation where the rainy day fund is going to be depleted, and it's going to end up being depleted quicker than anyone is talking about, I believe. And so it's going to be very surprising, I think, because these projections aren't showing it to many of us when we have to start talking about hard decisions. And if we could have more realistic projections, that would be very helpful for us moving forward. So I understand the budget secretary is involved in that process as well. And even if it means we have separate dialogues on what that would mean going forward, if we could do that moving forward, that would be very helpful for us. Thank you.
Thank you.
Thank the gentleman. Representative Friel.
Thank you very much. Madam Secretary, I want to go back and I'm going to pick up on budget as my colleague from across the aisle was talking about, but in a slightly different way. And I think often we make short-term budget decisions that have long-term impacts, and we may try to save $1 here, but that might end up costing us something later as you know the years go on. And so I was thinking about some of the discussions earlier about what makes us healthy individuals, and we're talking about some of the social and economic, determinants of healthcare and how access to food and housing and things like that can affect community health outcomes. One of the other things that can do that is, genetics, right? You can just be born unlucky. I'm on high blood pressure medicine. I have been since my 30s. I've gone up in weight and down in weight, and I'm still on the medication, right? It's my lot in life. But we have drugs that can help us. Obesity, people that are overweight. Do you agree that is a long-term health risk, and that sometimes if we could solve for that and make people healthier and give them opportunities to be healthier, over the course of their time in their life, it's going to bring down healthcare costs? Is that a true statement?
I think there's plenty of data that obesity is correlated, particularly long-term obesity, with some poor outcomes.
So if we had a drug that could help one of the most important determinants of long-term health, like a GLP-1, just for weight loss, wouldn't that be, maybe in a short term it's a cost to us, but in the long-term overall cost of the healthcare on that individual, couldn't you see that as being a savings?
So I wish I had an answer for that question right now. We talked a little bit about this a year ago with diabetes and GLP-1s. There's significant data out there that is absolutely the case for someone whose diagnosis is diabetes. because these drugs have been used for a much shorter period of time in individuals who are simply taking them to lose weight, we have a lot less data. But those studies are underway. The Medicaid Research Center at Pitt is doing one of those studies looking at our population here in the Commonwealth. There are other entities that are doing these long-term studies. We were recently talking to some researchers at Penn and seeing if we could assist in any way to make sure they had all the data that they needed, looking at long-term outcomes. And they're looking at things like, does it increase ability to hold a job? You know, lots of different factors. And so at the moment, in our immediate moment, I have to make decisions for 3 million people in a program that is under enormous financial stress right now. And we are narrowing the program to eliminate that one coverage aspect for GLP-1s. But as conditions change, as maybe price of drugs change, or we get additional data that shows that these have a long-term positive impact, we can always reconsider that decision.
That's good, because I think we get trapped all the time in these one-year budget cycles and not looking at, well, what is the cost 5 years from now from the decision we met today? And I would suspect, if I was to ask you, if you were to control a population health risk, like obesity, through creating jobs, food programs, work, transit, or a shot, which would be the cheaper way in order to control for that? Then I would suspect GLP-1s are pretty cost-effective in the long term, what it's going to cost Pennsylvania to manage the health and community health outcomes.
We'll
And
wait
that's
for
for
we
us.
have to wait for the data.
Yeah. Thank you.
Yeah, thank you.
Thank the gentleman. Chair Klunk.
Thank you, Mr. Chairman, and thank you, Secretary, for this afternoon's questioning session. My first question goes to our psychiatric residential treatment facilities. There's one in my region, serves a number of youth in my community, and as we've heard, the new proposed regulations that are still being finalized will likely have additional staffing, accreditation, training, and other additional heightened requirements. And this will likely correspond with an increased cost to these providers to provide the services to these youth. So my question is, how are these increased costs to providers for these increased regulations reflected in the governor's proposed budget, so that providers are not solely absorbing this cost for this additional regulatory burden?
Yeah, those regulations, what is their date that they will go into effect? We still have a little, when is it? So we're like 2 years. Yeah. We're probably at least a year, maybe 2 years away from those regulations going into effect. So I think they're still going, they're not even out yet in final form. So not to put you off in any way, but it's not an eminent issue, and so there is nothing in this year's budget for those regs. But as we get closer to see what those look like in final form, then much like we have talked about in our other programs, there will be a look at trend and other costs in the behavioral health program, and then that all ties back into rates, and that would be incorporated at that time.
And that's something that I think we need to have that conversation of, the increased regulations, it increases the burden on these providers, which ultimately drives up the costs. And we have to balance children's safety, but also, the ability to fund and cover the cost to provide these services. So Deputy Secretary Miller Wilson, during the Senate's appropriations hearing, you said that the OCYF rate study about the gap in child welfare state approved rates and the rates that counties are actually paying providers was completed, and that your office was reviewing the findings with the PCCYFS. But it's my understanding that PCCYFS has not seen that particular study. So if your office did in fact share the study with PCCYFS, can you, after the hearing, please provide that to us so that we can see that that was provided and to whom it was provided?
Yeah, sure.
All right, just checking, always on, okay. Yes, we can, after the hearing. That rate methodology study is dated, and I'll say at the outset, 2019 rates, we're in a different place in a different time. If anything, they've gone up, and to be candid, it's time to take another look at the rate methodology across the board for all providers, whether they're represented by an association or not. So with regard to rate methodology, we're committed to reviewing that, modernizing it, but that's going to take a fair amount of input.
Well, thank you for that, and I appreciate the department's looking at this particular issue. My last question is regarding Leading Youth for Excellence Center here, just right down the road. So this has been all over the news, Secretary, about this closure. And there have been varying reports about why the center was closed, including that the staff failed to report a suicide attempt, that staff did not properly report the escape of a number of juveniles, that staff used physical force. There were also reports of deplorable conditions. And we also have heard that the center had voluntarily subjected itself to biweekly monitoring by DHS. So my question is, when did DHS become aware of these deficiencies in the center's operation? And when did you guys begin those biweekly monitorings? Because, you know, it sounds like this probably didn't happen overnight, that it's not like, boom, we have all these issues at this center. So when did you know, and what are you guys doing to take a full report and look at what happened and where the breakdowns were?
So Representative, I urge you to read the emergency removal order that is publicly available online. And the facility does have rights to appeal. They have filed an appeal. I cannot discuss this at this point any further.
Thank you very much. And as this process works through, look forward to learning more about what worked and what didn't work, because we want to make sure that our children are safe. Thank you.
So do we. That is the #1 goal here.
Thank the gentlelady. Representative Malagari.
Thank you, Mr. Chairman, and thank you, Secretary Akush. I'm going to jump right in. I want to talk about minimum wage a little bit, if that's okay. So picture this. You're, for example, a mother of 2, and you currently earn minimum wage. Do you qualify for benefits under SNAP or medical assistance?
If you are a mother of 2 making $7.25 an hour, you would qualify for both of those programs.
All right, so how would the increase in wages then help these individuals and their families?
Well, if our minimum wage was $15 an hour, that individual, that family would double their income. Now, for a mother of 2, that person probably would still qualify for some benefits. And I don't have that chart right in front of me exactly. But for a single person at $15 an hour, they would no longer qualify for Medicaid or SNAP.
So for the family, they may still have to
They might still have some
help.
supports, yes. Mm-hmm.
The next question I have is, we know that our childcare workers often earn low wages. So what is the impact to many of them of the increase in the minimum wage?
Yeah. As I mentioned earlier, I think our average childcare worker right now is making $14.90, something like that, in that range. And so this would certainly have the impact of getting all of them to a minimum of $15. And as you know, sometimes that leads to someone who's maybe making $15.25 right now, they might get a little bit more. And so it would be a really important impact on them to help.
When you say all of them, how many of them would actually experience an increase in wages of those childcare workers?
Yeah, I'm not sure what the number was that we factored in for the childcare. We did put money into the budget for childcare workers to get an increase. I just don't know how many workers that was actually based on.
Yeah, what do you think the impact would be to these workers and their families if they get an increase?
Well, it'll be very positive. We'll continue to enable them to have more dollars that they take home every day and provide for their own families. And, I know the governor has proposed, or actually you all passed last year, I'm going to mess up the name of it, but it's the income tax credit for working families. And for a family like this, these increase in wages, because it's going to be coupled with both now a federal and state protection of some of those funds, it really will put more money in their pockets, which is a huge opportunity.
And it would be a benefit for them too, that's
Oh,
for
yeah,
sure.
very much a benefit.
What other programs and services are available for people if they, say, lose eligibility for programs like medical assistance and SNAP?
So if it's a child, they'll be able to move over to CHIP. And CHIP has a graded premium structure. So at certain incomes, CHIP is still no cost to families. And then at higher incomes, there is a shared cost for the CHIP premium. And then we do have quite high income families who buy insurance for their children through CHIP, usually because that child has significant needs, and those families may pay a full premium cost because they have resources that would support that. For adults, they would typically then move into Penny, and this is an area where I do think we need to be very, very mindful of what's happening at Penny and what the premium tax credits are now in this sort of new world for these folks that are making a little bit too much to qualify for Medicaid. We do want to make sure that they're going to be able to afford Penny. During the Medicaid unwinding, we had great experience with this. We created a portal, and we automatically sent people's information over to Penny, and they ended up enrolling, I think, 80 or 85,000 people who unwound, no longer were eligible for Medicaid and took them into Penny. And so my hope is that if there is any work to backfill what's been lost in these advanced premium tax credits federally, that we really do focus on this population of individuals who now, hopefully, with the minimum wage, will no longer qualify for Medicaid, but we do need to make sure they can still afford to purchase a plan through Penny. So that would be personally, my number one priority for where, if there's any additional funding that's going to go into this, that's where it goes.
I appreciate that. And it looks like my time's wrapping up, but I'm going to ask one last question. Are there programs like subsidized childcare for which we as legislators should consider the impact to families of losing benefits if their wages increase?
I think it's primarily Medicaid. There is actually higher income brackets in SNAP than Medicaid. So I think at this juncture, it's Medicaid, and then what we did talk about earlier, maybe we can have even a more gentle off-ramp from Child Care Works.
Thank you. Thank you, Mr. Chairman.
Malagari on timeout tomorrow. Okay. Representative Mullins.
Thank you, Chairman. Thank you, Secretary, again. First, has the department ever considered the quarterly nature of the budget adjustment factor, and that it really creates some difficulty for providers to report their or to adjust their projections in revenue every 3 months? And how would the department stand on, or perhaps consider an annual?
Yeah, it's interesting you say it that way, because from our perspective, we're getting the most up-to-date cost information from them. And so I would think they would not be for that, because then it's one time a year that they get to tell us what their costs are, and that's the only adjustment they get. As it stands today, we get quarterly information from them on their costs, and so those costs are readjusted every quarter. And then, again, within the constraints of what's been appropriated, they might get an increase some quarters. And so I would find it interesting. I've never heard a provider say to me, we only want to do this once a year.
Okay. Interesting. Just trying to think outside the box.
Yeah, no, I get it. Yeah. I'm sure it is burdensome for them in some ways, but they've been doing it for so long. They all have systems. It's all pretty automated. Like, they just push us their data. And it would really limit their ability to account for any changes in their own costs over the course of a year. So,
understood.
Yeah.
Thank you. Moving on, the Legislative Budget and Finance Committee and the Joint State Government Commission have performed studies and issued recommendations on the IDA system and found massive workforce shortages and turnover. Just wondered if you could update us on some of the things, some of the ways that the department is implementing or pursuing those recommendations from the study?
Yeah, as I mentioned earlier, this is really becoming a success story. Again, I'm not checking the box, but we've made a huge amount of progress. So because we've been able to increase rates for DSPs, we're seeing that that budget allocation is actually translating into dollars in their pockets. That's been very successful. We've got our vacancy rate down to 14%, which is the lowest it's been in a number of years. And then one of the things I'm really most excited about is that the people that do this work are so deeply committed to their clients that they help. But many of them never saw a career path for their profession. And now we have worked with providers to develop or to enable the providers to support their workers to get a credential. There's actually a certification program now, a national certification program. And the workers that complete this successfully then would be eligible for increased pay and kind of moving up a ladder. And so we've had several of our providers take advantage of this opportunity, and we're hearing from them that they have now 94% retention of workers because the workers are feeling very valued, as they should, and they're also seeing a way that they can move up a career ladder by taking advantage of some of these opportunities. So we're really pleased with how things are going, and we're also always very interested in ideas that others might have on additional things that we can do that would make sure these employees realize how much they are valued and continue to professionalize this work and create these opportunities for advancement in this field.
Excellent. And only because the light's still green, I know we talked about county mental health services earlier, but as a follow-up, wanted to focus on the federal funding cuts and how the department and the administration is preparing for the impact at the county level for those mental health services when those federal dollars are jeopardized and reduced.
Right. So when it comes specifically to behavioral health services, many of the individuals that we serve will likely qualify for an exemption from work requirements. Anyone with a serious mental illness or SUD in treatment will be able to qualify for an exemption, at least for some period of time. And so far to date, the federal cuts haven't been explicitly directed at behavioral health services. It's been more what we talked about earlier, the assessments that we use to help fund our program, those state-directed payments. So far, this is an area that we have a little bit less concern about. But, if we lose $20 billion of funding over a course of a decade to this program, and particularly the MCO assessment, if that gets ratcheted down, currently we get about $2 billion a year from the MCO assessment that goes right to directly fund the Medicaid program here in the Commonwealth. And so the loss of even a portion of that would be a loss that would be difficult to make up. So it's all part of the bigger angst. But for BH services specifically right now, there have been some cuts to SAMHSA and some other grants and things like that, but the core Medicaid program so far looks okay.
Thank you so much.
Yeah. Sorry, Mr. Chairman.
Chairman Struzzi.
Went on about that.
We're getting there.
We're almost there. Thank you, Chairman Harris. So it's been a very long afternoon, and we've heard a lot of differing viewpoints. So I think it's important that we offer some simple clarifications. And I would simply like a yes or no answer on this. If people meet the eligibility requirements for Medicaid, both the current and new requirements, they are still eligible to get benefits. Yeah, is that true?
Yes, if they're found to be eligible, then they will get the benefits they were eligible for.
Okay, as long as they meet the requirements.
Correct.
And then related to emergency room treatments, if people show up to the emergency room, regardless of what they look like, regardless of their status, regardless of their insurance coverage, they will receive treatment. Is that true?
That is correct today, yes.
Okay. Thank you for that. And ye shall know the truth, and the truth shall make you free, as is written on the ceiling of this very chamber. So thank you for those clarifications. I want to get back to some budget discussions. As I said from the outset, the current proposal for your department is roughly about $22 billion, an increase of about $1.3 billion over the current year funds. And a big chunk of that is the capitation and community health choices appropriations. And in fact, that probably, most likely, definitely would have been higher if we hadn't had the increase of 570 in the FMAP. But the question is, these continual increases really are unsustainable. As we're looking at our revenues for Pennsylvania, while we hope that they will increase based on some of the changes that we've made policy-wise, right now in front of us, it's a gap of about $6.5 billion based on revenues versus the governor's current proposal. So my question is, Section 1115 waiver initiatives aside, what can we do to reduce the cost, the rate of growth as far as some of these necessary expenditures? What can we do to make sure that we can continue to provide these services to vulnerable Pennsylvanians while at the same time looking at perhaps a more sustainable budget amount moving forward?
Mm-hmm. So I think, again, just to kind of recap some of the things we've talked about today. One is making smart investments in these programs that can actually reduce the spend in our Medicaid programs. And again, these are pilots, and they'll be independently evaluated. So if they don't actually reduce the spend in the Medicaid program, we will end them. And if they do reduce the Medicaid spend in our Medicaid program, we'll probably ask you if we can expand them a little bit, because it will make sense to do so. So I just want to make sure you understand the whole, like they're pilots and they'll be independently evaluated. We also, in addition, we did get that FMAP increase, which is just nothing we have control over. We were just beneficiary of that. And I do want to reiterate that we saw what was coming in July with H.R. 1 passing and the way the budget negotiations were going. We took action to change our program ahead of the 2026 contracts. And, if we'd had an on-time budget, we probably could have changed it a little bit more if needed. But we did, not only did we stop covering GLP-1s simply for weight loss only, we also made the other pharmacy changes, including allowing the use of certain biosimilars instead of the original drug. We also made some changes around pay for performance. And so had we not done all of that, and we were able to do that before giving our MCOs their 2026 rates, which we have to do right around after Labor Day in September. And we also gave our MCOs their best and final rate. We did not negotiate with our MCOs. I know many of you got phone calls about that. Mm-hmm. We did everything we could to make 2026 contracts line up with what we thought the budget was maybe going to look like by the time the budget was done. So we took all those steps, and had we not done that, we would have been looking in our physical health Medicaid program at an 11.5% increase instead of the 3.8% that we are in right now for 25-26. So we are being extremely mindful of what is in our programs. We haven't had a chance to talk today about all of the ways that we are monitoring the potential for fraud, the way we are making sure that third-party liability is being fully accounted for. We have recouped over $400 million in recoveries this year, and we are continuing to make sure that our payment error rates are as low as possible. Like we're doing all of those pieces to make sure that the program is being run extremely well. And so as time goes by, if these H.R. 1 cuts come to pass, and there is still time to change them, but if they come, we're going to have to make some very difficult decisions.
Well, I appreciate your efforts. I think we need to do everything we can to reduce those costs while still providing the necessary benefits that people need, because as I said, it's simply unsustainable to continue to have a $1 billion increase year after year. So thank you for being here today.
Thank the gentleman. All right, almost there. I have a few questions. Don't you put that timer on me.
Ooh.
Turn that on. Don't do that. See, she always trying to play me because she think I'm gonna ask a lot of questions, but I'm not. But I might. All right. See, just start the timer again. All right. Couple questions, Secretary. And first of all, thank you for your indulgence today. We were able to get all of our members in, and we really appreciate you being here. So I want to talk about a little bit about Washington, D.C. and the ramifications of, H.R. 1. I'll call it that because I'm not going to call it beautiful. It's not. Anyway, that is more, a lot of people talk about it as, a savings of funds. Would you consider it a savings of funds or a shift in funds?
This is at least for here in Pennsylvania, it's a significant shift to Pennsylvania taxpayers. And we have two examples of that in this year's budget. One is those SNAP admin costs, $87 million. And the other is reducing the FMAP on the emergency Medicaid, $18 million. So this is like the first tranche of tangible dollars being shifted onto Pennsylvania taxpayers.
So we continue to send a significant portion of tax revenue to Washington, D.C., to the federal government, and yet with this bill, we're actually getting less, at least with this program, we're actually getting less of that money back. Would that be a fair assessment?
Compared to prior years, that's 100% correct.
Right. So when folks are excited about that bill, they would be more excited about the fact that we're leaving more money in Washington, D.C., and not actually bringing those dollars back to Pennsylvania. Would that be a fair assessment?
For my programs, yes.
Okay, thank you. I was really amazed when I heard one of my colleagues talk about how, they don't have a hospital in their county. Look, I'm from Philadelphia, and many times we have an abundance of riches in certain areas. I can literally go outside my house. I live in Grace Ferry. I can go outside my house and I can turn around, and literally at the skyline, I see Penn Medicine, and right next to Penn Medicine, I see the Children's Hospital of Philadelphia, right? I've been in South Philly my whole life. I've always seen Penn Medicine and Children's Hospital of Philadelphia. And over the years, both of those centers centers of healthcare have grown exponentially, so much so that people from all over the Commonwealth come to Philadelphia to get treatment for themselves and for their children right there in Philadelphia. So to hear that there are some counties in Pennsylvania that don't have a hospital at all is mind-blowing. It's also mind-blowing because when I look at the data on what H.R. 1 out of Washington, D.C. does to rural Pennsylvania, it just blows my mind. In fact, the data on your very website says that around 470,000 people out of the 1.8 million recipients are from rural Pennsylvania. Does that figure seem fairly accurate to you?
Yeah, it's, I think 21% of rural Pennsylvanians are in Medicaid, and they're about a quarter of the whole Medicaid population.
So it says 470,000 out of the 1.8 million are in SNAP, 720,000 out of the 2.9 million are MA recipients. They're from our rural counties, and that is readily available on your website. Does that seem about right? Yeah. Also, looking at the data, according to this new legislation out of Washington, D.C., about 36,000 of those folks will lose SNAP benefits. 74,000, almost 75,000, will lose MA coverage from folks in rural Pennsylvania. Does that seem about right?
Yes.
Okay. When I just look at the members in this room who are on the Appropriations Committee, about 565,000 of our constituents would lose that coverage under this particular bill. Out of that 565,000, many of those folks are from rural Pennsylvania. And so it blows my mind that in counties where they don't even have hospitals, that anyone could be excited about this piece of legislation at the federal level that is literally going to decimate many of those counties with regards to health care coverage. Would you agree with that statement?
It's going to be very, very challenging.
Thank you. Based on this data, rural communities will experience some of the challenges that we've discussed here today. And we talked a little bit about this with the insurance commissioner. What will the loss in coverage for MA do to the places that do have hospitals in rural Pennsylvania?
So if a person loses their Medicaid and they have no other way, they can't afford to buy a plan on Penny, then, and they have a health emergency and go to the hospital will care for them. And it is, that patient maybe can go on a payment plan, but they're certainly not going to be able to pay their entire bill in one shot. As a consequence, that increases medical debt for that hospital and the person. The hospital ends up, and we've seen this over many years, they will increase their prices. They will look to have higher reimbursements from insurance companies because basically they're cost shifting their costs to the people who do have insurance. And so everybody else.
So let me. I want you to go back. So, because I want folks at home to really understand this. Person in rural Pennsylvania who doesn't have health care, a person that's a part of the 720,000 people who are on it now, but the 75,000 who are probably going to lose health care under the bill out of Washington. Any one of those 75,000 people who lose health care go to a hospital. The hospital by law is required to see them. The hospital will take care of that person, but the hospital won't get paid for it. And so they'll go on a payment plan or something to try to cover it, but the hospital still doesn't get the money. And so according to you, and you're a medical professional, correct?
Yep.
Okay. According to you, what you're saying is that the hospital will then raise their rates on the commercial insurers so that we can pay for it, right?
Right. They call it cost shifting, right?
So wait.
They're putting the cost on the folks that can pay.
So the federal government is already doing a cost shift by keeping more of our money in Washington, D.C. and making us pick up the tab. Now you're telling me by kicking people off of health care, we're going to have another cost shift onto us because of the folks who are going to get kicked off of medical assistance. Is that what you're
That's correct.
saying?
It'll lead to higher insurance premiums.
It'll lead to higher insurance premiums for all of us.
Correct.
What happens to that hospital after a while if they continue to run a deficit?
Well, they usually end up closing. They usually end up closing. So they might try to consolidate with other hospitals. Maybe they get purchased by a larger hospital system. They sometimes are subject to private equity coming in because they are really looking for help, or they close.
Have we seen any examples? I mean, I know you had a map here today. Have there been any examples of hospitals or places closing any recently?
Well, the most recent one was Bradford.
And where is that located?
In McKean County.
Okay.
And it's right up against the border. And they're actually owned by a hospital in New York, which has really complicated any kind of solution for them. And they announced 2 weeks ago that they're closing.
Would you consider that rural?
Oh, yeah.
So
Very.
that would be rural Pennsylvania?
Very rural.
So we're seeing places in rural PA who already don't have enough hospitals losing more hospitals?
And this one did obstetrics.
Wow. That bill doesn't sound too beautiful anyway. I want to shift gears real quick. Can you explain to me again DHS and how DHS verifies someone's eligibility for an MA program or for SNAP?
Sure. So when someone applies, we check 15 different databases. Some are federal, some are state. And if there's any question or any discrepancy about information that is in those databases that's electronically available, then we ask the individual to provide documentation that is consistent with whatever we need.
We've heard a lot of conversation about undocumented people. I don't like to use the other term, but undocumented people here in Pennsylvania. How do they qualify for your services?
They do not.
I'm sorry?
They do not.
Okay. I know some folks have been making an issue about if someone goes to a hospital and they are in need of emergency care, do they get that emergency care at the hospital?
They do.
After that, then what happens?
So are you talking about someone who's here without any kind of legal status?
Yes.
So if they qualify for Medicaid, if they meet the income eligibility, if they meet Pennsylvania resident status, there's several things. If they can qualify for Medicaid through those ways, then they can get emergency Medicaid for that situation that brought them to the hospital.
But only in an instance of an emergency situation.
Correct. There's criteria. It has to be life-threatening. Having a baby counts, which sometimes feels
Good, 'cause we
life-threatening.
wouldn't want to throw our
but,
mothers
right,
out
exactly.
on the street
So there's a
with
couple,
babies.
there's a set of criteria.
Mhm.
But if you meet one of those criteria and you are here without any legal status, then you can qualify for emergency Medicaid for that situation.
But you said having a baby or life-threatening situation.
Yeah, severe pain. There's a couple different.
Oh, okay. That's what I thought. Okay. So let me ask you this question. A lot of folks we often talk about waste, fraud, and abuse. Here in Pennsylvania, both the Attorney General's office and the State Inspector General can investigate fraud that we see in programs that you administer, correct?
That's correct.
Okay, well, during 2024, the Office of the Attorney General collected over $11 million due to fraud convictions. The Office of the State Inspector General collected over $22 million. Do you know how much of that money was collected from undocumented people?
I would imagine none of it.
I'm sorry?
I would imagine none of it
Wow.
because we do not enroll those people in our programs.
Okay, wait. So the waste, fraud, and abuse that the Attorney General and the Inspector General are charging people with in recovering funds, it's not waste, fraud, and abuse from undocumented people?
Correct. In fact, they get the information about those providers. The big numbers are from providers, and we refer those cases to the Attorney General. Recipient fraud gets referred to OSIG, and providers or practitioners who are practicing maybe outside of their license get referred to Department of State because they hold the license. So we do all that referral because we can't investigate or bring charges against anybody. And so all of that work that we do, which we're really proud of in partnership with them, they get the information from us because we see something suspicious.
Wow.
We refer it all to them. I'll give you the recipient numbers for OSIG. Last year, we referred 19,232 cases that looked suspicious to my team to them. OSIG went through them. They found 53% were fine, and they ended up with 674 referrals for criminal prosecution. So, and all of that is from data we send them. That's what gets left out of this whole fraud conversation, is that we're one of the best in the country at identifying and prosecuting fraud because my team takes this so seriously. We refer them these suspicious providers or recipients or practitioners that are outside of their license.
But I just want to be very clear. That fraud is being committed by full-blown citizens.
Correct.
Not undocumented people.
Correct.
Wow. This is very interesting. So to sum it all up, waste, fraud, and abuse, fine. We should weed it out. But it's being committed by our own citizens, not undocumented people, right? And the only time that those undocumented people would get medical coverage is if they appear at a hospital or something with a life-threatening or emergency situation, right? And many of those hospitals that would service those folks, many of those hospitals that are in rural Pennsylvania are seeing an issue because many of their folks are about to get kicked off. About 75,000 of them will be kicked off from their health care coverage based off of the big bill out of Washington, D.C., correct?
Correct.
And many of those rural places already have healthcare deserts because they don't have hospitals in many of those counties, right?
That's correct.
And most recently, the hospital that just closed was in one of those rural areas. So it would seem as though that hospital closed in an area where there's already a desert. This bill out of Washington, D.C. will kick more people off of health care, which will exacerbate that problem and cause more of a health care crisis in many of those rural places. Would you agree with that?
I would agree with it. The Hospital Association of Pennsylvania agrees with that. Everybody who's involved in this space understands that this is going to fall very hard on rural hospitals.
And that sounds like the truth. The truth shall make you free. Thank you so very much, Madam Secretary, for being here with you. Gloria, again, happy birthday to you. Hopefully you'll enjoy it for the next few hours. And with that, that is going to end our session with the Department of Human Services. We'll be here tomorrow at we'll be here tomorrow at 10 a.m. 10 a.m. where we'll be speaking to the Department of State. And with that, this hearing is now adjourned.